Seeing a comment that the pretest is not clickable. If it's not clickable, I'm assuming it's because of the device that you're using. Can you long press and see if that allows you to copy? If it does, please just copy, paste it in the browser of your choice, Safari, Firefox, Chrome, Microsoft Edge, whichever one works for you, and paste it there, and it should work. And if it's not working, please let me know. We try and troubleshoot and see how else we can help. All right, so good evening again. About 30 persons have done it so far. 177 of us here, 78, 79. Numbers are growing wonderfully. So please, you have about 2 minutes left. Then we're going to hand over to our moderator for the first session and take it from there. Two minutes left. 2 minutes left for the pre-test. 2 minutes left, and then we go into our program. Good evening again. Good evening. So we have about a minute left for the pre-test. Hi, Doctor. Hi, Dr. Henry Dawkins. Hi, everyone. Thank you for joining us. So I'll continue to post the pre-test in the chat. Please go ahead and complete the pre-test. You only need to do it once, and then we'll head over to our agenda. All right, so that's it for the pretest. I'm going to hand you over now to our moderator. Our moderator is Dr. Aileen Standard Golson. She's a dedicated educator and accomplished medical professional, currently serving as a lecturer at the Department of Community Health and Psychiatry at the University of West Indies Mona campus. Her education started way back with her Bachelor of Medicine, MBBS at the University
not
of
so many
Indies.
ways, Sam.
It's only one way back. Wonderful person, wonderful friend. Ladies and gentlemen, I hand you over to Dr. Aileen Standard Golson. Have a wonderful evening.
All right, thank you very much. Yes, it really is way back when now. And it really is my pleasure to be the moderator for this very important session this evening. The Caribbean College of Family Physicians, Jamaica chapter, again is putting on a very timely webinar, Challenges of Managing Hypertension in Primary Care. If we are in primary care and we go a day and don't see a patient with hypertension, it means we are in the middle of some kind of epidemic or pandemic like COVID, because in any normal day, we are going to see one and more patients with hypertension. So it's something that has to be very much on our front burner. And we have a list of very distinguished family physicians who are going to share their experience and knowledge with us today. To get things started, as is the norm with CCFP functions, we are going to start by invoking the presence of the Almighty. And I would ask Dr. Aldith Buckland, immediate past president of the CCFP Jamaica chapter, to lead us in prayer. Aldith?
Thank you, Aileen. Good evening, everyone. Let us pray. Dear Lord, thank you for life and health and sickness. Thank you for the learnings that we get in life and suffering. Give us the spirit of discernment and guide our thoughts to enable us to take care of ourselves and be of service to our patients and fellow man. Thanks again for everything, Lord. In Jesus' name, amen.
Amen. And thank you very much, Dr. Buckland. Dr. Seni Onanuja is the current president of the CCF Jamaica chapter. And I know that she would like to bring greetings and welcome you all to this webinar tonight. I believe, Sam, that you have something recorded that you are going to share with us.
Yes.
Good evening, everyone. Our specially invited guests, Drs. Polly William Green, Jordan Eaton, Jose Humphreys, Anna J. Brown Morgan, and Dr. Colin Allett, moderator, Dr. Ellen Standard Golson, esteemed colleagues, Administrator Lynn Thompson Hyatt, our host and IT support personnel, Mr. Samuel Heron of Oldgate Solutions, as sponsors, Indus Life Sciences and Medimpex Jamaica Limited. Friends, ladies and gentlemen, a pleasant good evening to you all. It is indeed my pleasure and honor on behalf of the Caribbean College of Family Physicians Jamaican chapter to bring you greetings and welcome you to this evening's webinar, main focus, Challenges of Managing Hypertension in Primary Care. Why hypertension? Hypertension affects more than 30% of the adult population worldwide. That is more than 1 billion people around the world. It is the main risk factor for cardiovascular diseases, especially coronary heart disease and stroke, but also for chronic kidney disease, heart failure, arrhythmias, and dementia. Hypertension is a major cause of cardiovascular morbidity and mortality in the Americas and especially in the Caribbean. About a third of adults in Jamaica have hypertension, half of the hypertensive are not controlled on their medications. It is among the major non-communicable chronic diseases and continues to pose a significant health challenge for both the developing and the developed countries. According to the American College of Cardiology, hypertension is one of the primary modifiable risk factors for cardiovascular disease, and both in prevalence and severity increase with age. Globally, our elderly population is growing rapidly. Mortality and morbidity from hypertension is expected to increase as a result. However, treatment is clearly demonstrated to be beneficial. In the guidelines on hypertension management put out by the Ministry of Health in 2014, hypertension was among the leading risk factors for mortality in the world. In the Caribbean region, the Caribbean Epidemiologics Center, CAREC, member countries, hypertension has been stated as one of the 5 causes of death since 1985. General practitioners play a critical role in the battle of improving blood pressure control among hypertensive, which for many of us represent a large percentage of our patient population. The Caribbean College of Family Physicians, which came into being in 1987, has been a major continuing medical education provider for general practitioners and hence has organized this seminar on hypertension and related mental health issues. As such, we have with us distinguished and well-accomplished speaker, a practicing family physician and a tutor for many years, Dr. Pauline William Green, and psychiatrist, Dr. Jordan Eaton, both of whom hails from a very own Jamaica. We also have a cadre of panelists who have agreed to give their perspective on what can be done to reduce the numerous uncontrolled hypertensives. From the ranks of the Caribbean College of Family Physicians and Jamaica, Dr. Anna J. Brown Morgan, and from the neighboring islands of Barbados and Antigua and Bermuda, Dr. Colin Allet and Dr. Jose Humphreys. We are greatly pleased and highly appreciative that they were willing to share their time, talent, and expertise with us this evening. A wholehearted welcome to you all. I feel confident that we will certainly be well informed and enriched by this evening's presentations. On behalf of the college, I thank and welcome you all and invite you to sit back and enjoy the presentations. Thank you, and God's richest blessings.
Thank you so much, Dr. Ananusho. Thanks for the welcome, the greetings, and for setting the tone for why it is that we are looking at this condition of hypertension this evening. Thank you so much. To open the batting this evening, still a cricket fan, notwithstanding the trials and tribulations. The first person, the opening bat this evening is Dr. Pauline Williams Green, one of our senior family physicians in Jamaica. She pursued undergraduate medical training in Cuba and her postgraduate family medicine training at the University of the West Indies. She completed her DM in family medicine in 1994. She has worked as the coordinator of the family medicine program at Mona in 2001 to 2006. And she, throughout all of this, since 1992, she has maintained a thriving holistic private practice in a rural community family wellness center in Livingston, Jamaica. She puts into practice all the principles and attributes of the ideal family physician. It's my pleasure to ask you to welcome her today to speak about managing resistant hypertension in primary care. Dr. Pauline, the floor is yours.
Thank you so much, Aileen, for that warm introduction. And good evening to all our participants. Happy to see you all. Sam, I'm looking for the share, but I'm not seeing it. Not sure why. I've seen it earlier. I want to share my screen and just want to, while we look out for the share, I just want to just thank Dr. Senia Onanuju and the other members of the CCFP Secretariat for
Are you seeing it now,
allowing,
Doc?
yes, I'm seeing it now, for allowing me the privilege of presenting on a topic which is dear to my heart. Let's see, where's the slide share now? So the screen is up and I am looking to get the slides going. Oh, I know what happened. Let me just do that. Let's try it with file.
No, it's slideshow. So
Yeah,
file, home, insert, draw. Keep going across. File, home, insert, draw, design, transition, animation.
oh, I know.
And then it
What's
says
happening?
slideshow.
Okay, let me try.
Or something's blocking it. That's why.
Yeah,
If you go down,
I
to where
found
you
it.
can.
I found it.
Oh, okay.
It should go now. There we go. So I've been told I have 30 minutes and I am trying really trying to be good with the time. So thanks very much to Dr. Sandra Bolson, our moderator, and thank you to the CCFP organization for asking me to present in this fashion. And yes, our topic, management of resistant hypertension in primary care. And so this is my security guard patient who asks, Doc, why is my blood pressure always high? And we're going to try and answer his question today. We're going to talk about resistant hypertension from the primary care perspective. We look at the epidemiology, its importance, identifying resistant hypertension, looking at the causes of resistant hypertension. We must look at secondary hypertension. And then I leave you with a 7-step plan for managing this condition. So what is resistant hypertension? Well, let's start with hypertension. It's defined as systolic blood pressure more than or equal to 140 millimeters of mercury and or diastolic blood pressure greater than or equal to 90 millimeters of mercury. Resistant hypertension is elevated blood pressure above the goal, despite concurrent use of 3 antihypertensive drug classes by the patient. And this would include your long-acting calcium channel blocker, ACE inhibitor, or an ARB, and a thiazide type diuretic. And despite this, blood pressure is still elevated. The drugs should be given at maximally tolerated doses. But let us go further. Resistant hypertension includes the patients who are controlled. They are at 120/80, say, they are at goal, but they are taking more than, 4 or more antihypertensive drugs. And let's talk a little bit more about the prevalence. In Jamaica, hypertension among adults is about 33.8%. You see for men, almost 32%, for women, almost 36%. Now, the the prevalence of apparent resistant hypertension is about 12 to 15% of the population. And this is from the American Heart Association. It's more prevalent in older adults, in males, persons with obesity, diabetes, and renal disease. Dr. Sene mentioned that over 100 million people have hypertension, but this resistant hypertension affects 10 to 20% of the hypertensive population. What is the impact of resistant hypertension? There is increased risk of cardiovascular and cerebrovascular disease, such as heart failure, stroke, kidney disease, and other complications. There is a significant economic burden in increased healthcare utilization and costs, more frequent medical appointments, diagnostics, and medications. There's increased hospitalizations and visits to the emergency department, and it leads to a poor quality of life. So, how do we recognize resistant hypertension? To do this, we have to rule out those with the false or the pseudo-resistant hypertension. Let's talk about pseudo-resistant hypertension. And we consider this by looking at three factors: the doctor-related factors, the patient-related factors, and the medication-related factors. Just want to, we will talk a bit more about the white coat hypertension and so on, but want to highlight that under medication-related factors, it's not just drug interactions and side effects, but the pharmacokinetic variability of drugs. Let's talk about white coat hypertension as a form of pseudo-resistant hypertension. This is where the office blood pressure is above goal, but out of office blood pressure is normal or below target. And to rule this out, we need to consider 24-hour ambulatory blood pressure or home blood pressure monitoring. We'll say more about this later. It's thought that the prevalence of white coat hypertension is somewhere around 10 to 15% of the general population. It's associated with higher risk of cardiovascular disease and total mortality in persons without antihypertensive treatment compared to normotensive persons and hypertensives on adequate treatment. So it's not as innocuous as I certainly thought. Another cause of pseudo-resistant hypertension is, as we said, white coat hypertension. And to get a better idea, comparing the out of office with the home blood pressure, I want to focus on home blood pressure monitoring. These are measurements self-performed or with the assistance from family members. It excludes readings of blood pressure at work, at a pharmacy, or made by a healthcare practitioner at the home. The patient should be taught correct methodology and measurement schedule. Often the recommended schedule is 7 days monitoring, so no less than 3 days. And it's usually a routine day, the things they do ordinary, nothing out of the ordinary, in other words. So routine work days are preferred. We do mornings and evenings, so it's twice per day. Wait about 5 minutes, sitting at rest, and we suggest that they repeat it 1 minute later, since there's usually a lower reading at that time. Now, the home blood pressure threshold varies, but this is according to the European working group. It should be below or at 135/85 millimeters of mercury. Now, it has been shown, and I've showed my reference here, home blood pressure is superior to out of office blood pressure in predicting strokes and chronic kidney disease. Can you say who has resistant hypertension here? There's a whole lot of persons. We can talk about this later. All right. Here's another problem or another reason for resistant hypertension is improper measuring techniques. Firstly, let's look at several categories. The first category is the patient preparation. Before the patient comes into your office, did they just have a meal? This is likely to increase the blood pressure. Alcohol ingestion before taking the blood pressure can go either way. It can either be increased or it can be lowered. Caffeine use, however, increases the blood pressure. Nicotine use and exposure increases the blood pressure reading. The device model bias and calibration error is bidirectional. It depends on the device. It could increase it as well as it could lower the measurement you're getting. And what about the patient's position? If the legs are crossed at the knees, many of us like to do that. If you take the blood pressure then, it's going to be higher than it really is. No, attaching your cuff to the patient can affect the reading as well. If the cuff is too small, the blood pressure measurement will be higher. If it's a larger than appropriate cuff for that person, it's going to be lower. And if you use a paretic arm in somebody who has had paralysis or hemiparesis, then it's going to be higher in that limb. Taking a measurement while you, the doctor, are talking or the patient is talking is going to also increase the reading. And deflating the cuff too quickly tends to increase the systolic blood pressure and as well lower the diastolic blood pressure, and so gives you a false reading. Let's talk about the patients now as a cause of pseudo-resistant hypertension. And that is the biggie, non-adherence to medications. Now, adherence is the extent to which a person's behavior, and in this case, taking medications, corresponds to agreed recommendations from a healthcare provider. Unfortunately, 40% of clinical appointments do not address non-adherence. We forget to ask the patient, how many tablets have you missed for the past month? How many times have you not taken your tablets? And let us remind ourselves, as the number of antihypertensive medications increase, so does non-adherence. Non-adherence is the dominant type of pseudo-resistant hypertension in patients who have been referred for renal denervation, meaning they'll be referred for surgery to denervation of the kidneys because they are considered to have refractory hypertension, just not responding to any medication. And a third of them really haven't been taking their medication. And so we have to ask about whether they're taking their medication. Lifestyle factors are also important. Patients who are hypertensive and their intake of salt is high because we eat from the cook shops, we have in the fast food and the many processed foods. That's a source of a lot of salt. Lack of physical activity and just being obese. And then there's workplace stress. I have to share a case with you. I'm a family physician, and this one stood out for me. A patient, 67-year-old male, was controlled in my practice on verapamil, 240 milligrams daily for many years, over 15 years. Then he retired. And all of a sudden, I noticed that his blood pressure was going down and he was slowly coming off his medication until his blood pressure measured both in office and at home was perfectly at goal, 120/80, 110/70, on no medication. He had stopped working. He hated his job as an orderly. in a hospital, by the way. Alcohol excess is another cause. Excess alcohol will increase your blood pressure. Sleep disorders, and we have read about shift workers whose blood pressure tends to be elevated because of their disordered way of working or very few hours of sleeping. And we will talk about obstructive sleep apnea in a few minutes. Drugs which interfere with the effectiveness of antihypertensive also cause resistant hypertension or pseudo-resistant. NSAIDs, we talk about the sympathomimetics, oral contraceptives slightly, but it does increase blood pressure. Erythropoietin, antidepressants. I've had experience with venlafaxine. Put a person on it and their blood pressure went up by at least 10 millimeters of mercury. Non-prescription weight loss supplements which contain ephedra will raise the blood pressure, so we should ask about it. And then there's our and the patient's treatment inertia. You know, the patient who every time they come, the blood pressure is 160 over 100. Mrs. So-and-so, you're eating too much salt or whatever. But we need to be proactive. Identify the patients with possible pseudo-resistant hypertension, confirm that the blood pressure measurements are correctly taken, and use the stepwise treatment algorithm for treating hypertension. We must encourage interventions for our non-adherent patients. Find out why they're not taking the tablets, and let's seek to address that. All right, so moving right along, I've spoken about pseudo-resistant hypertension, but there are also secondary causes of resistant hypertension, and this is often overlooked in our practice. What is secondary hypertension? This is elevated blood pressure that results from an underlying, identifiable, often correctable cause. And it makes up 5 to 10% of all hypertensive. And when should you consider secondary hypertension? The patient has poor response to therapy, and you know they're taking the tablets or the medication. There's worsening control in a previously stable hypertensive patient. Think secondary hypertension. And of course, if their blood pressure is really high, systolic blood pressure more than 180, or the diastolic more than 110. And if you have the clinical findings of significant hypertensive target organ damage, or there's just very strange, no family history, nothing suggestive of hypertension, but they're having very high blood pressure. There's an ABCDE mnemonic to help you remember the causes, the secondary causes of hypertension. And we will actually go through them a little bit later, so I'm not going to say long on this slide. Just remember A, B for breweries, C for excess, all the C's, D for drugs, and E for endocrine disorders. Let's start with A, accuracy of diagnosis. So you must ensure correct procedures was followed in measuring the blood pressure. Have at least two separate readings, and use home blood pressure monitoring, or if they can afford it, ambulatory blood pressure monitoring. Remember, white coat, we have to exclude white coat hypertension. And we're going to talk now about obstructive sleep apnea, which is a secondary cause. And this comes under the A as well. And OSA is the recurrent episodes of partial or complete upper airway obstruction during sleep. In fact, hypertension and OSA are often found in the obese, male gender, and persons who are elderly. Persons who have OSA suffer recurrent episodes of upper airway inspiratory collapse during sleep, leading to hypopnea or apnea. And this causes transient hypoxemia and hypercapnia. The patient awakes because of the hypoxemia and hypercapnia, and terminate these spells and then hyperventilates. There's a simple evaluation screen that we can apply in our office. It has a sensitivity of 84% if you find 3 or more of the following. They tell you they snore, or better still, you ask, do you snore? And then they sort of look very shy and shameful. Yes, my wife tells me I snore. They're often tired. They have been observed to stop breathing, and high blood pressure is why they're in your office too. Their BMI is more than 35. They're older than 50. Their neck circumference increases more than 40 centimeters. And they're usually male, but trust me, there are lots of female around as well. So if they have 3 or more of any of these clinical features, you should think of the obstructive sleep apnea, and the acronym is STOP BAN. How do we evaluate OSA? There are many sleepiness scales, but the one often used is the Epworth. And of course, refer to your sleep lab, your pulmonologist, anybody who does home sleep tests. Thank you. The next secondary, or I should say cause of secondary hypertension that I want to focus on is primary aldosteronism. It's overlooked, but it's more common than we think. It's thought to be anywhere between 3 to 13% prevalence in primary care settings. So we should bear that in mind when we see our hypertensives. It's significant because of the impact on cardiovascular and cerebrovascular events. The diagnosis is a 3-step process. First, you screen, then you can send to the specialist, but if you have the ability, you can confirm and do the exclusion test. And then the specialist does the subtype differentiation. The screening test is aldosterone renin ratio, ARR. The less, less sensitive is the serum potassium and measuring the aldosterone. Measurement of the renin alone is less specific. Who should be screened? Anybody who has hypertension, stage 2 or 3, and they're not controlled on the conventional medication. They have getting their ARBs, RAs, calcium blocker, etc., diuretic. Or if they are controlled, but they are on 4 or more drugs. We're often taught about the spontaneous hypokalemia or hypokalemia induced by hypertension or a diuretic, but this is rare. Less than 4% of persons with primary aldosteronism will present with this. Of course, if in an incidental finding of a CT scan of the abdomen, there is an adrenal mass and hypertension, think of primary aldosteronism. And the combination of hypertension and obstructive sleep apnea, one should think of primary aldosteronism. Who should be screened? Anybody who had an early onset of cardiac or cerebrovascular accident due to hypertension or a family history of this, and they were younger than 40 years, screened for primary aldosteronism. Guess what? Every first-degree relative of a patient that you find with primary aldosteronism should be screened. If you have a patient with atrial fibrillation, which is not explained by structural heart defects or other known conditions, then you should consider primary aldosteronism as well. This test, unfortunately, the screening test, the plasma aldosterone to plasma renin reactivity is expensive. Is expensive, and it's not available in Jamaica. The labs actually do collect the sample, but they send to overseas. And then, of course, you need to do the CT scan of the adrenal glands to look for any possible adenoma or tumor. I'm going to go quickly now. Other causes of secondary hypertension: renal parenchymal disease, and this is of course, renal insufficiency or elevated BUN or creatinine levels, all the symptoms of chronic kidney disease. And this is evaluated by the creatinine clearance and doing renal ultrasound to look at the renal parenchyma. And then there's renal vascular disease. And we should, think of it, if we encounter an abdominal bruit, and this is evaluated by the magnetic resonance angiography. Excess catecholamines, that's using too much of the over-counter drugs with, let's say, pseudoephedrine, or in the perioperative setting, or in acute stress, or somebody always with tachycardia. And we evaluate this by confirming that the patient is normotensive in absence of high catecholamines. And I just have to give you one case where I had a 38-year-old truck driver. He was just involved in an accident where his truck overturned. He suffered no physical injury, but he was in my office for examination. His blood pressure was over 200 and 3/120 millimeters of mercury. So I thought, wow, hypertension. But then he was still very stressed out. Brought him back 2 days later, his blood pressure was perfectly normal. Coarctation of the aorta. This, is decreased or delayed femoral pulses, and it should be evaluated by Doppler or CT imaging of the aorta. Cushing's syndrome, we were taught the weight gain, the moon face, the dorsal hump, fatigue, weakness, hirsutism, amenorrhea in women, purpose striae, and the truncal obesity. And this has to be evaluated by the dexamethasone suppression test. I would certainly refer right away if I saw somebody like this. Drugs, just going to spend the last couple of minutes here. Remember nicotine, smoking, excessive alcohol intake, and just going to share another story about NSAIDs. Male, 77 years old in my practice, treated on NSAIDs for years, high levels of NSAIDs for his spinal osteoarthritis. And he was on X-Forge HCT, wasn't controlling the pressure. His cardiologist added hydralazine. And then he just decided, he didn't tell me, just decided to stop the NSAIDs. He wasn't feeling it, but the pain was still there, he said. So he was just going to live with it. And the man collapsed one morning, shortly after. Brought to my office, blood pressure was in the floor, 90/50, thereabouts. Sent him to hospital. No, it wasn't a heart attack. No, it wasn't a stroke, blah, blah, blah. They just rehydrated him, he was fine. We figured that because he had come off his NSAID, he didn't need so many different drugs for his hypertension. And his blood pressure is much better controlled now. Don't forget, high salt intake. Salt is a drug. High salt intake. Pheochromocytomas. We always send in for VMAs. If we find persons with paroxysmal hypertension, headaches, diaphoresis, palpitations, then we send them for their urinary catecholamine metabolites. If this is positive, send them to the specialist. And hypothyroidism, if we suspect it, we do our thyroid functions. Same for hyperthyroidism. So for both hypo and hyperthyroidism, if suspected, we recommend that we do our thyroid functions, ultrasound to examine the thyroid, and then refer as appropriate. And finally, hyperparathyroidism. Recurrent kidney stones should get us thinking about this, and they should be evaluated with serum calcium and parathyroid hormone levels. Acromegaly, never seen that myself, but we learn it because it comes with hypertension, but headaches, fatigue, and the enlargement of the limbs, hands, feet, and tongue. And we should do the necessary growth hormone levels and refer if it's positive. So I'm going to leave you. This is my last few minutes now with a 7-step plan for dealing with resistant hypertension. First, number one, confirm treatment resistance by checking the patient's office blood pressure and that it's over 140 over 90, despite taking 3 or more antihypertensives at optimal levels, and make sure the antihypertensive include a diuretic. Exclude pseudo-resistance. Is the patient adherent to an optimal treatment plan, and is out of office blood pressure elevated? Identify and address lifestyle factors, which we spoke about earlier. Discontinue or reduce interfering substances, the NSAIDs, all right, over-counter drugs which contain simple mimetics, possibly the oral contraceptive, and any other drug that might be causing this. Screen for secondary hypertension, and we went through this briefly. Optimize antihypertensive treatment, enhance diuretic therapy. Think about chlorthalidone or indapamide, which are long-acting. Use spirolactone. Aldactone is a brand name. It reduces arterial stiffness as well as lowering the blood pressure. And you can consider alpha-1 and beta-1 adrenal receptor blockade. As a primary care practitioner, I do not hesitate to refer to a hypertension specialist if I suspect blood pressure is not at goal after 6 months, despite what I've done, or if I suspect secondary hypertension. This is my recommendation to you. Thank you for listening.
Thank you ever so much, Dr. Williams-Green. You must have timed this to perfection. A very good use of time and a lot of information that has been shared. I know there will be some questions, and I would ask our audience to put the questions in the Q&A link, and we will take questions for both this and the next speaker at the end of the next speaker. So Dr. Williams-Green, as always, a wonderful presentation, a wealth of information, the personal sharing of the patients and the real life experience, not just the book and references, but the real life experience means a lot to us. So thank you very much for that. And please hold on. You can go ahead and look in the Q&A so you'll be ready to answer the questions later on. So we're going to move from Dr. Pauline to our next presenter, Dr. Jordan Eaton. Dr. Eaton did his MBBS at the University of the West Indies, graduated in 2014. After his internship and senior house officer time at UHWI, he found that he had a passion for working with mental health and psychiatry. And subsequently, he went to work at KPH, Kingston Public Hospital, specializing in treating patients with multiple mental health problems on open general medicine wards. During this time, he also helped to organize and execute multiple training sessions and mental health conferences with the Caribbean Institute of Mental Health and Substance Abuse. He actively strives to combine his passion for mental health and well-being to help patients and their relatives to embrace a holistic therapeutic outcome. He is enrolled in the postgraduate psychiatry program at the University of the West Indies and is a senior resident, and is also a physician with Pure Jamaica Healthcare, with an emphasis on the treatment of conditions with medical marijuana. Dr. Eaton currently serves as the Senior Registrar at the St. Catherine Health Department. I believe he is actually on call, but hopefully he will not get any calls during his time with us, because I think all of us know that there is a great link between mental health and chronic diseases on a whole, and certainly mental health and hypertension. So Dr. Eaton is going to speak to us about mental health disorders in patients with hypertension. Dr. Eaton, over to you.
Thank you so much, Dr. Golson. Good evening, everyone. Going to try my best to stick within the time limit. It also dawns on me that I actually need to update my bio because that was a combination of the old one and the new one, but we will press on. So good afternoon again, everybody. Thank you so much for having me. Today we'll be talking about mental health disorders of hypertensive patients. And we are going to just dive in. So unfortunately, I hold over from my days in the residency program. I'm very obsessive about my presentation. So we have an outline. So this is what we're going to be covering today. What is mental health? What are the common mental health conditions? And then the bulk of our presentation, overlap between hypertension and mental health disorders. And finally, what do we do? So mental health, according to the WHO, state of mental well-being that enables people to cope with stresses of everyday life and realize their abilities, learn well, and work well. It is an integral component of health and well-being, and it affects our ability to make decisions, build relationships, and shape the world we live in. And it is a fundamental basic human right. It is crucial to personal, community, and socioeconomic development. We look at some common mental health disorders, depressive disorders, anxiety disorder, the psychotic disorders, and our affective or mood disorders. But I like to bring these numbers home. So what numbers are we actually talking about? So WHO estimates as of June this year, our current population is 8,045,311,447 persons in the world. Now, in all countries, mental health conditions are highly prevalent, meaning it's about 1 in 8 persons living with a mental health disorder. And the prevalence of different mental health disorders varies with gender and age. So looking at data from 2019, PC, pre-COVID, because we're still running the data post-COVID, 301 million persons living in the world with an anxiety disorder. And of that, 58 million include children and adolescents. 280 million persons living in the world with depression, and of that, 23 million are children and adolescents. 40 million persons experience bipolar disorder, and persons with bipolar disorder are at an increased risk of suicide. 24 million people, or 1 in 300 people worldwide, are persons living with schizophrenia. And persons living with schizophrenia have a 10 to 20-year life expectancy that is shorter than that of the general population. So if you go with the biblical 70 being 75, we're looking at a patient with schizophrenia who is dying between 55 and 65. And this is usually as a result of complications of chronic medical conditions. And then we have the uncommon ones. 14 million persons are living with an eating disorder, and about 3 million of those are children and adolescents. 40 million persons living, children and adolescents are living with a conduct or a dissocial disorder. And then we have neurodevelopmental disorders, intellectual disability, autism spectrum disorder, attention deficit hyperactivity disorder, amongst others. And of note, especially with what's happening with Palestine, Israel, Gaza, and what's brewing with Guyana and Venezuela, is the prevalence of PTSD in areas with high conflict. And if you want to bring it home, living in Jamaica is technically speaking high conflict because we experience trauma on a day-to-day basis. Speaking about Jamaica, about 3% of our population are living with a depressive disorder, women more common than men. And this is data based on the 2017 Jamaica Health and Lifestyle Survey 3, if I remember correctly. 4.1% have an anxiety disorder. Again, women are greater than men. However, most new cases of anxiety disorders are appearing in Jamaicans between 20 to 34 and 35 to 59. So this is the time when you're supposed to be maximizing your potential or actualizing on the potential that you have established in your years previous. Again, based on these PAHO numbers, psychosis is estimated at about 2.09 per 10,000 persons, and psychosis and schizophrenia together account for 80% of mental illness-related public clinic visits nationwide. And I can speak to this specifically because of my work in Spanish Town right now. Majority of the patients that we see are diagnosed with a primary psychotic disorder. So what's the overlap between mental health and hypertension? it's actually bidirectional. So what we know is that having a chronic illness increases the risk of developing some mental health condition, such as depression or anxiety. We also know that having a mental health condition increases the risk of developing a chronic illness like depression or like diabetes or hypertension. So let's dive in a little bit more. The relationship between it is complicated and it can happen via multiple mechanisms. One option is a natural progression of aging, wherein persons living with mental illness are living longer and are subject to normal conditions of age, such as increased cholesterol, hypertension, or diabetes. The development of chronic conditions can be as a side effect, however, of medication used to treat these mental health conditions. So let's make it practical. Medication side effects. In terms of our antipsychotic medications, we have our first generation or second generation or typical or atypical antipsychotics. With medications such as the typicals or the first generations, you're looking at Haldol, Stelazine, Modicate. You can see things like weight gain, and associated with this is diabetes and hypertension. Even if you don't have the weight gain, how the medication actually works can actually increase your resting blood pressure. Second generation medications such as risperidone, quetiapine, and olanzapine are notorious for their metabolic side effects. And you're looking at development of impaired blood glucose, increased blood pressure, increased cholesterol, and the associated weight gain. And that's just the antipsychotics alone. Antidepressant medications, just choosing to focus on SSRIs here specifically, weight gain, notorious. Right? You're also going to see ECG abnormalities across multiple categories of medications, whether it's antidepressants, anti-anxiety medications, antipsychotic medications, etc. So you can have tachyarrhythmias, tachycardia, and QTC, corrected QT prolongation, which can predispose you to lethal tachyarrhythmias like torsade de pointes, which can be life-threatening. So when we look at chronic hypertension to mental illness, there's a significant association between hypertension and psychological symptoms such as depression, anxiety, and anger. These symptoms are accompanied by alterations in the neuroendocrine systems or may have a range of behavioral correlates, which may in turn have persistent adverse effects on physical health. And as we heard in the previous presentation, that case scenario of the porter or the orderly rather, who had resistant hypertension or chronic high blood pressure that was on multiple medications. And as soon as he left his job, blood pressures started to plummet because the situation that was actually predisposing it to his hypertension, the neuroendocrine processes and the behavioral correlates had been removed, hence and therefore his blood pressure naturally overcorrected. And multiple studies have shown the connection between chronic illnesses and mental health conditions. What studies? Because we like evidence, I'm glad you asked. I've highlighted a couple of them. So Stein et al. In 2014, depression, anxiety, binge eating disorder, bulimia nervosa, substance use disorder were significantly associated with the diagnosis of hypertension, with the odds ratio going from 1.1 to 1.6. And the number of lifetime mental health disorders was associated with subsequent hypertension in a dose-response fashion. Gladigo et al. In 2015, is that 2015? My thing is blocking. Was that 13? You guys can see I can't, unfortunately. Patients with severe mental illness were more likely to smoke, be obese, have dyslipidemia, and metabolic syndrome compared to the general and native populations of Australia. Patients were more likely to have diabetes in the general population, but had similar rates to the native population. Meaning, persons with mental illness, even though the baseline rate was the same between Indigenous persons and Caucasian Australians, we noted that the persons who had mental illness and severe mental illness were more likely to have these increased rates across the board. Patients had similar rates of hypertension to the general population. Crenchey et al. In 2014 noted that hypertensive patients experienced symptoms of anxiety, 56%, stress, 20%, and depression, 4%. And as a coping mechanism, a significant relation was observed between spiritual beliefs and anxiety. the chi-squared value being 13.352. Depression, the chi-square value was 6.2, and stress, the chi-square value was 14. What it says is that stress among patients increases their likelihood of medication non-adherence. So we're again seeing the complicated interplay. So on one hand, you have hypertension, which is predisposing you to development of anxiety or depression or stress. The coping mechanisms can help to offset this. However, what you're noticing as the stress increases, there's an increased likelihood of them not taking the medication for their hypertension, thereby worsening their hypertension outcomes. And we like summaries because I talk too much and this is a lot of information. So very few people go through life without any chronic health challenges. People with cancer often have depression. People with schizophrenia often have diabetes, and people with chronic pain often both have physical and behavioral health challenges. And amongst everything, depression and anxiety remain the most common conditions. And that is one arm. So that was looking at how mental illness can affect hypertension. But what about the reverse? We touched a little bit on these disease processes, whether it is depression or anxiety, affecting your ability to function, or a condition like bipolar disorder when you're manic, or schizophrenia when you're psychotic, affecting your judgment, and you therefore not taking your medication or tending to your health. But what about the reverse? What about poorly managed hypertension as a complication? So if you have a heart attack, studies have shown that you have increased association with depression. I believe it was Dr. Martin et al. In 2012 who did a study that showed that at University Hospital that there was an increased association of depression in persons post myocardial infarction. And that was it, that is within the Jamaican population. We know that uncontrolled hypertension puts you at increased risk for stroke. And what a lot of people don't recognize is that when you have a stroke, yes, you can have dementia, specifically vascular dementia, but you can also, as a result of it, have depression, you can have anxiety, you can have manic episodes, and you can have psychotic episodes. Patients with heart failure were linked with higher rates of depression and anxiety. Patients with kidney damage were associated with higher rates of depression and anxiety. All of these conditions are complications of hypertension, and poorly controlled hypertension, therefore, can increase your risk of developing mental health conditions. So let's make it reasonable. Let's make it relatable. What do we do? Where does the family physician fit in? So this is from the American Association of Family Physicians, and this was this year in July. In another sign of increased awareness of the importance of mental and behavioral health, the United States Preventative Services Task Force recently issued 2 final statements that recommend, for the first time, that clinicians screen all adults 19 to 64 for anxiety disorders and screen all adults, including those 65 and older, for major depressive disorder. And I've included this because 1, this is from the Association of Family Physicians. 2, this is recent. And 3, it is exactly what we're talking about here. The interplay between our aging population and mental health conditions, as well as those who are at risk of developing mental health conditions as a result of their underlying medical comorbidities. So when we talk about screening for depression, let's just do a quick run through. The 2 major things that we need to consider are major depressive disorder and a persistent depressive disorder, and they're very similar. For major depressive disorder, you need 5 of 9 symptoms for 2 weeks or longer, and one of the 5 symptoms, it must include one of the major 2, which is depressed mood, more than half, sad down depressed mood, more than half the days for 2 weeks, or anhedonia, meaning loss of interest in things for pleasure, loss of interest in things for fun, or loss of motivation to do things for most days over those 2 weeks. Persistent depressive disorder you're looking at, it is like depression, but it is low-level depressive symptoms, but it's extended, meaning you're having a 2 or more year history of 4 of the 9 symptoms. And what is interesting about persistent depressive disorder is you can have a diagnosis of persistent depressive disorder where your mood is at a baseline lower level and stressful events in life happen, such as a pandemic, such as end of relationships, such as losing your job or new job stressors that can actually precipitate the worsening of your symptoms of your persistent depressive disorder, and you sink into what we call a major depressive episode, and it gives rise to the phenomena of what we call double depression, persistent depressive disorder with a concurrent major depressive episode. But that's a lot of psychological terms. So how about we keep it simple? There are screening tools that we can use for depression, and they are freely available online. And I love them because they are objective and they're easy to administer, and they go up in level of complexity. So there's the patient health questionnaire 2, which is 2 questions. Have you been having the depressed mood or the anhedonia for 2 weeks or longer? And if they're having one of those symptoms, it says to you, screen further. And it says you can use the PHQ-9, which is the 9 symptoms of depression. And these forms are very simple. 2, 9, or 15 questions, and you're rating 0, 1, 2, or 3. It takes about 5 minutes. I use it in my own office. I use it in clinic. I use it in the hospital. It's an objective assessment. It is the patient answering in black and white and it's giving a number that can then be quantified to say very low incidence or no depressive symptoms, mild depressive symptoms, moderate depressive symptoms, moderately severe depressive symptoms, or even severe depressive symptoms. Another alternative is the Hamilton Depression Rating Scale, which is the HAM-D. And again, God bless a digital age. Google, you can literally type in and it will spit out a PDF format that you can print, have the patient fill out, bring them back in 2 weeks' time, have them fill out again, and you can compare and contrast. Or they can do it on their smartphone because, as we like to say, there is an app for that. And it allows you to track the patient's symptoms. So for example, a patient comes in complaining of low mood, feeling sad. Something has happened and you're talking to you, you're talking to your family doctor, and you're a little concerned. You don't think you're not sure if it is true depression or not, either because it is acute in onset, it hasn't met the 2-week criteria, or you're just not 100% sure. You give the patient a questionnaire to fill out. Have them come back in a month's time. You repeat the questionnaire. You can compare the score that they did today with the score they did a month ago, 2 weeks ago, 3 weeks ago, and you can look, and there's an objective assessment. Easiest way to make an assessment. Similar for anxiety. The most common that we're going to look at is a generalized anxiety disorder, excessive anxiety and worry. It occurs more days than not for at least 6 months at a number of events, and the person finds it difficult to control the worry. Again, screening tools. The GAD-7, much like the PHQ-9, very straightforward. 7 questions, 0, 1, 2, 3, gives you a number. An alternative to that, if you want to be a little bit more in depth in terms of what symptoms you can look for, use a Hamilton Anxiety Rating Scale. Now, other symptoms to screen for, psychosis. Please, please, please do not forget psychosis. If a patient comes in and they're complaining of problems sleeping and they're not feeling well and their appetite is going down, yes, it can be depression, but let us take a moment to consider the possibility of this being prodromal psychotic symptoms. We have to look at the positive symptoms and the negative symptoms. Positive symptoms, are they having hallucinations? Are they having delusions? Meaning, are they hearing voices talking to them? Or do they feel anything strange, like people might be watching them, people might be following them? They're a little bit more nervous and on edge because they think something is going to happen to them and they can't explain it. You can look for disorganized speech or thought, and that's just in how the patient is conveying their ideas to you. It's not logical, it's not sequential, it's not organized, and it's difficult to follow the flow of the conversation. Do they have grossly disorganized behavior? As happened with one of my patients, going up on the roof, picking mangoes and stoning people in the community with the mango. Or are they taking off their clothes and going to stare into the sun? Or are they setting their clothes on fire? Just frankly disorganized behavior. Or you can have catatonia, where they just completely shut down, they're minimally responsive. You can also have negative symptoms, they're affect, there's not that range of emotion on the face. It's almost like a mask, it's blunted. You have alogia, where they're not talking as much, anhedonia, they're not doing things for fun that they normally do. Asociality, they're becoming more withdrawn. And then avolition, they're just not motivated to do anything more than just stay one place, not tending to any of their basic needs. Another condition, dementia. Neurocognitive disorders, surprisingly, well, no, not surprisingly, unsurprisingly, as our population ages, the number of cases of dementia are going to rise. And the problem is we are not encouraging our patients and our relatives to be looking out for things. So in the first world setting, most common cause of dementia would be Alzheimer's type. However, when we look at the data within Jamaica, specifically from Professor Eldemire Shearer, what we found was that we actually have a predominance of what we call mixed presentation, meaning the patient has signs and symptoms that are in keeping with an Alzheimer's type picture. They're having gradual memory deficits. It's starting off with they're having problems naming names, remembering where they put things, forgetting how to do basic things. And it is usually very subtle, but it's getting worse. And it is noted by either the patient, the caregiver, or the physician. And that's the Alzheimer's type. But as we spoke about before, a lot of our patients in Jamaica have hypertension and diabetes that is uncontrolled. And with uncontrolled hypertension and diabetes, one of the major complications we're worried about is a stroke, which can give you a vascular dementia. But it doesn't have to be a full stroke with the classic presentation. You can have what we call small vessel ischemic damage, meaning that the very fine blood vessels that are supplying the brain matter itself are being damaged as a result of the chronicity of their uncontrolled diabetes, hypertension, high cholesterol levels. And while it's not going to produce drastic cranial nerve findings or long tract findings or orientation changes, you will get subtle changes that are gradually happening over time. It's almost like you're picking different areas of the deep brain matter and it's being knocked off. And by the time you get a cumulative effect, you are looking at a vascular dementia, which is a phenomenon. So I will give a case that I saw recently. 65-year-old gentleman known to have hypertension, recovering from multiple myeloma, had a massive right-sided infarct and has significant left-sided hemiparesis. The problem was about 2 or 3 weeks after his stroke, when he seemed to be at his baseline, his attending doctor did a cognitive assessment and said, yes, he's having deficits, but we're going to give it time to see if it improves. I then get called in 3 to 4 months after because he's now having agitation, behavioral changes, problems sleeping. And the question is being asked to me, is this anxiety? And the answer is no. This is a function of vascular dementia. And in examining the patient, you see the deficits come up because you're not fully oriented in time, place, and person. They have problems with naming, repetition, concentration, attention, and comprehension. And one of the fastest ways to do this is, again, the screening tools. I will never forget when I was completing residency, if you have a clinic of 50 patients, as told to me by my consultant, Dr. Martin, one of the best consultants I've ever had, if you have a clinic of 50 to 100 patients and you need to screen quickly for dementia, before you even decide who is going to get a mini mental status exam or a MOCA, the easiest way you can assess if they need to be screened further is a clock drawing test. Give them a piece of paper, ask them to draw a clock face on it, and ask them to fill in a specific time, 3:30. It is testing multiple domains at once, their ability to draw a circle, their ability to visuospatial processing in terms of placing the numbers at an appropriate spacing and an appropriate within the actual face of the clock. And then to understand 3:30 means the shorthand is on 3 and the longhand is on 6. So it's testing multiple domains very quickly. And when you have patients who have impairment in their clock drawing test, these are the patients that you screen with your mini mental status, your Folstein or your MOCA, so you can pick them up quicker, and then you can begin to investigate what the cause of the dementia is and institute management changes or refer them to a specialist. So things to consider before treating: let's rule out an organic cause. Complete metabolic profile. This is inclusive of your B12, your folate, your HIV, and your VDRL, because these conditions can cause psychiatric presentations and they can cause symptoms that mimic other conditions, such as dementia. B12 dementia deficiency, completely reversible. Folate deficiency, reversible, right? We need to rule out some other psychiatric conditions if it is that you want to start medication. So if you're thinking this patient has depression, before you put them on an antidepressant medication, you can ask the questions about bipolar disorder. Similarly for psychotic disorders. And as always, if you're not comfortable treating, that's okay. Consults and referrals are more than fine. As a general rule, if it is that you are comfortable making a diagnosis of depression or anxiety, and you're worried about your patient in terms of especially chronic hypertension, as we were told about earlier, the side effects of medication, two of the best medications that you can actually use are Lexapro and sertraline. Well, Lexapro, escitalopram, and sertraline, Zoloft. They're SSRI medications. They're actually first-line medications that are indicated for both depression and anxiety. And why I'm highlighting these two is because they're very tolerable. They are indicated for older patients as well as younger patients, and they have a very low risk of drug-drug interaction. So they're relatively speaking safe, and their half-lives are known. So it's not like fluoxetine that's up to a week. This is 24, 26 hours, so you can comfortably prescribe. All right? So I've been pontificating. Let's wrap up. Summary time. Mental health conditions and chronic illnesses have a bidirectional relationship. Mental health conditions can cause chronic illnesses such as hypertension, either from the stress or from the medication. And similarly, chronic illnesses like hypertension can trigger mental health conditions such as depression or anxiety. And the two have an interplay where they can worsen each other. We need to screen our patients, so you can use any of the screening tools that we've mentioned: the PHQ-9, the GAD-7, the Hamilton depression, the Hamilton anxiety, the mini mental status examination, or the MOCA. All of them are available online, ready to download, ready to print. We need to investigate our patients. So CBC, UNEs, LFTs, TFTs, please. TFTs, B12, folate. Let's not forget those because they can imitate many things. Calcium, magnesium, phosphorus, C13, VDRL, and some neuroimaging. For depression, anxiety, your SSRIs are first line. If you're not going to take anything else away from this, Lexapro, Zoloft. And before you start a medication, rule out any other possible conditions. And if you're not comfortable, that's fine. You can call a psychiatrist for a consult, or you can refer your patient for a consult. Thank you for your kind attention. Hopefully I didn't bore you too much.
That was certainly much too stimulating to be boring. Thank you so much. It was a wealth of knowledge, so well presented, so practical, and so timely as well. So thanks very much for that, Dr. Eaton.
My pleasure.
I just want to turn off the timer. Good. So we've had two excellent presentations from Dr. Polly Williams-Green and Dr. Jordan Eaton. And there are some questions in the Q&A. We do have, thanks to their timeliness, the full 15 minutes. I see that Dr. Williams-Green had got a start, and she did answer some on in writing. I will just read those so everybody has the benefit of it. What is the thinking about the wrist blood pressure machine, which are popular for our patients? Dr. Williams Green, and that was from Dr. Marsh. Dr. Williams Green said they are becoming more acceptable, but always compare with a mercury sphygmomanometer to check for accuracy. And I imagine, Dr. Green, you'd mean that when you are first using it, you check it for accuracy and then intermittently?
Yes. Ask the patient to bring the wrist machine and bring the instructions, because each one has a different kind of, they may tell you to put the hand across the heart, or they may tell you to put it on a table, which is at the level of the heart. So the instructions are very important, but they are more and more acceptable if it's a good brand, but it's always good to compare it in the office setting as well.
Okay, and then the next question that was asked by Sean Allen was, quite a few hypertensive patients also take aspirin. Do all NSAIDs increase blood pressure? Which ones are more recommended for pain control? And Dr. Williams Green said aspirin does not increase blood pressure. Avoid or limit NSAIDs in hypertension. Use acetaminophen if possible. Use NSAIDs just for short periods. I don't think we need to add anything to that, Dr. Pauline.
No,
So
that's fine.
That's fine. So we'll move on to the question from Dr. Lord. Is this Dr. Lord from Barbados? You mentioned drugs, but what about the young patients who appear to be fit but use performance-enhancing drugs like anabolic steroids, stimulants, or supplements that can affect their blood pressure? You want to say a word on that, Dr. Pauline?
Yes. That, as he said, can you hear me?
Yes, I can.
Okay. It's more than likely will affect his blood pressure. You haven't said whether that young patient is also hypertensive. So if he's hypertensive, the blood pressure should be monitored both at home and out and in the office setting. Yes, using performance enhancing drugs like anabolic steroids. I have had no personal experience, but I imagine because it's a steroid, it's going to increase his blood pressure. So you have to advise this patient, if he's hypertensive or she's hypertensive, the danger of uncontrolled blood pressure. If they're not, it's a matter of monitoring the blood pressure. I hope this helps, Dr. Lord, and good to hear you.
Thanks a lot. I think you're off the hook now. We move to Dr. Eaton. Dr. Rick's Rooms has two questions for you. First one, she's asking, how often would you screen for anxiety and depression? So if you have a normal screen now, when should you consider repeating the screening?
Okay, thank you so much for this question, Dr. Rooms. Excellent question. So, first of all, you can do a once-a-year screen. So you establish a baseline. It's like doing an executive profile to know when everything is fine. So once a year is perfectly fine. Now, you can also use your clinical judgment. If this is a patient that you've known for 5-10 years and they have been married for 20 years and they've recently suffered divorce, loss, major life changes, things of that nature, your clinical acumen goes up a little bit higher and you say, I know we did this 6 months ago. Let's check in. And then you do it then. And then when you see the patient back in your office in another month or 3 months, you can repeat it again. There is no harm in screening too much. It is better to screen more often than less often, because when you screen more often, you can pick up subtle changes very quickly and you can start instituting management. So for example, for mild cases of depression and anxiety, or even stress and trauma, you don't even have to go with medication therapy. Supportive therapy in an office setting, talking to the GP just about your problem, talking to your family physician about your problems. It's ventilation therapy. And if your practice is busy and you're not comfortable doing that, that's reasonable as well. You may not even feel comfortable because you're not sure if this is appropriate or not. You can refer them for a psychologist or a counselor. So there are options abound. So to answer your question, at least once a year, but you cannot screen too often.
All right. I also want from Dr. Ricketts' rooms, how do you manage a patient with memory loss but no depression and normal mini mental status exam 4?
Okay, so that's getting tricky. So if the patient, so an excellent question again, because there is a phenomenon of pseudo-dementia, where a person, usually older, becomes so depressed, they can have symptoms that mimic depression. And if you treat them with so depressed, it can mimic dementia. And if you treat them with dementia medications, it's not going to affect the underlying cause. Now, if it is that this patient's depression score, history, and collateral information is showing nothing, and your mini mental status is still showing nothing, we have to consider something biochemical. Is this a B12 deficiency, a folate deficiency, or is this another medical condition? Could this be complex partial seizures? So we have to start, if everything else is normal, because psychiatry is a diagnosis of exclusion, usually go through everything else and then come to a psychiatric. So if it is that you're having memory problems, you have to do some other investigation, at least a CT brain and a full chemical panel, because it is not normal to have memory deficits and have no symptoms. The alternative is the patient is just dumping the symptoms that they're having. So we have to consider both a medical cause and if they're accurately reporting the symptoms, because let's face it, mental health is still stigmatized. We still don't want to talk about depression and anxiety, and that's okay. But we have to reassure our patients and our clients.
Thanks for that, Dr. Eaton. And to summarize what Natalie McMorris is asking, she is saying in a patient who may be illiterate or dyslexic, where the drawing of the clock would not be, you wouldn't be able to use that. Is there anything else you could use in lieu of that?
Right. So that is a challenge that we actually face with using these standardized testings, because they're developed for a first world setting or developed country setting that assume a certain level of literacy and numeracy. In a case like that, you don't need to use a screening tool. If it is that the patient, if it is that the relative, or if it's that you, the physician, notice that this person is having some symptoms that suggest memory deficits or could be pointing to dementia, you don't need to screen for it. You can make an assessment based on history alone and the examination, like doing their mental status examination. So for example, assessing your cognition, your full orientation in time, place, and person, short-term memory versus long-term memory, as well as simple things like concentration and attention. So one of my favorites is, and it's very subtle, because you ask the person to spell the word world, or you spell the word earth. And we can do that. But then you ask him to spell it in reverse. So if you can't do that because the person can't spell, you can improvise. So you say, for example, what are the days of the week? Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. Okay, great. Set them backwards now. Even a person who has no dementia is going to have a second or two where they have to process the information. But with a patient who has dementia, it is going to become very pronounced, because they'll start Saturday, Friday, Thursday, and you'll see the latency coming up. You will also see that they may just get distracted and they'll go Thursday and then they'll go back to Friday and then Sunday and then continue along. So you can make a clinical assessment without the screening tools.
Okay, wonderful. Thanks very much for that. Dr. Williams-Green, I'll let you off the hook too soon. Dr. Marsh is asking, can skin bleaching over a long period affect blood pressure? This is our last question now.
Dr. Marsh, I really don't know. I would like to talk to the dermatologist about that.
Yeah.
Really not sure. I would, first of all, we'd need to know what are they using. And we know some of the products contain, toxic substances like mercury, etc. Steroids, they do take a lot of steroids. So if the steroid is being absorbed, we expect the blood pressure to go up for that. So it depends on what they're bleaching with, what product. Certainly I would want to know, get an opinion from the dermatologist. But if you have such a patient, the thing to do definitely is to monitor the blood pressure at home and in the office. Hopefully, since they'll be doing it at home, if they see the blood pressure going up, that will help them to consider discontinuing.
Oh, thanks very much. And I do see we do have maybe a half a minute left. Dr. Eaton, I'm seeing in the chat, can you do a quick comparison
of SSRIs versus SSRIs? I was actually typing out a response, but the short version is this. SSRIs are actually the current recommendation. They're a little bit safer. They're also more cost effective. And what I was highlighting in what I was typing out is that there was a study that came out in the last week and a half out of Denmark. They looked at 90,000 persons over the age of 60, I believe it was, who were being treated for depression with antidepressant medication. And what they actually found was that the best medication that they found for tolerability and improvement of symptoms was actually sertraline, Zoloft. It had the best side effect profile. It reduced the chances of them having to change to another antidepressant medication, and it had a lower risk of affecting any other symptomatology in terms of chronic medical conditions.
Thank you ever so much. And I know if we were in a face-to-face setting, the applause would be great right now for both yourself and Dr. Williams-Green. Excellent presentations, very practical, down-to-earth things to do. And you can see the applause coming up on the side of the screen in the emojis. So thanks very much, Dr. Eaton, Dr. Williams-Green. We do appreciate your taking the time out.
Thank you so much.
Thank you very much. Moving right along and right on time, you know that any presentation like this is not possible without the input of our sponsors. So I would like to invite our representative from Indus Pharmaceuticals, Mr. Diadan, to do a presentation to us at this time.
Good evening, doctors, and greetings from Indus Life Sciences to the CCFP organizers, moderators, presenters, as well as participants. I want definitely, want to share this. I'm seeing more than 280 participants. Only CCFP can do this. And so I'm happy to be a part of CCFP today's webinar. From Indus Life Sciences, I just want to refresh a couple of our brands. Obviously, I just want to refresh one of our brands that we introduced in 2022, which I have been sharing with all the medical doctors in most of the webinars, which is basically for those patients who have these episodes of heartburn, hyperacidity, gastritis problem, flatulence, or acid reflux for that matter. And we know that first time in Jamaica, even though you could see in the screen as Jamaica, it is basically first time in Caribbean. We introduced this antacid, which is very popular, not only in Jamaica, as well as in other Caribbean now, which offers you this unique drug, alginic acid on it, which is basically an algae, basically a natural algae. And this algae has a benefit of stopping the acid reflux, as when it is taken new gel, the alginic acid in it interacts with the stomach acid and forms a foam, which is called as alginate raft, as you could see in the screen. And that alginate raft prevents the movement of stomach content from stomach into the esophagus, thereby the acid reflux is prevented. So especially those who are experiencing the acid reflux at bedtime, and when you have new gel with you, it ensures no acid reflux, that ensures good night's sleep. So to understand it better, how this alginic acid works, I have a small clip. When you see this, you will understand how nicely it works. As you see here, the new gel goes into the stomach. As it is taken, the alginic acid interacts with the stomach acid, and the alginate foam, which is the alginate raft, which is formed within 4 minutes of taking this antacid. And when the stomach acid content tries to move up into the esophagus, it blocks it. In number of times it tries, every time it is blocked. And this foam stays almost more than 5 hours. And after 5 to 6 hours, it gets completely excreted along with stomach content, with no residues left on in the stomach. And it does not interact with any medication the person is taking, nor with any food they are eating. So this is actually the composition of a new gel. As you could see, the alginic acid, which stops acid reflux as well as heartburn, and the regular magnesium hydroxide, aluminum hydroxide, magnesium trisilicate. We all know they neutralize acidity, and the dimethicone relieves gas. And the composition of magnesium hydroxide, aluminum hydroxide, and magnesium trisilicate, they vary of uniform of 250 milligram each, 250 milligram, that ensures no diarrhea or constipation. New gel is safe in pregnancy. I mean, all the 3 trimesters, safe in diabetes as it is sugar-free. As it is safe in pregnancy, it can be recommended for children less than 10 years of age. And for those who are experiencing gastritis pain, and we have this extension of new gel, which offers a unique oxytocin, which is just like lidocaine, a mucoso anesthetic drug, basically oxytocin, and it gives a coating to the stomach wall, and thereby gastritis pain, ulcer pain, and stomach pain, all those conditions, it could be really useful. And it has alginic acid again, it has magnesium and aluminum, magnesium trisilicate, and simethicone is the anti-flatulence medication. The only thing, new gel O is not recommended for pregnant mothers and persons less than 12 years of age. For them, new gel is recommended. By the way, both new gel and new gel O are over the counter, and the new gel will stay outside the pharmacy, and new gel O will stay inside the pharmacy, but still it is over the counter. Pharmacy will dispense it to the patients. And we have it in 3 different forms. We have the regular 200 ml pack, and we also have 100 ml, so smaller bottle is also there. Apart from this, we have introduced last month for people who are on the go, we have introduced single dose sachet, which is 10 ml, ready to drink liquid. No need to mix with water. You can just tear off this sachet and you can just squeeze it in the mouth, especially those who travel a lot or working in workplace, or those who go visits restaurant often. Instead of carrying the whole bottle, we can just sachet whichever, as many as you want. And they're respectively priced around $50 and $60 per dose. And this is the first time in Caribbean an antacid is available in ready to drink and a liquid form of new gel and new gel O. And before I wrap up, I just want to remind you, as being today's topic is on hypertension, we have our antihypertensive drug, Tell Me Fast. I'm pretty sure all medical doctors are aware of it. We have 40 and 80. The good news is that this is the most affordable Tell Me Sartan, and which is completely subsidized by NHF. And also we have for neuropathic pain, pregabalin, neurobalin, 75 and 150 mg. And we have this patient benefit coupons. My medreps will be distributing it to you, which helps them to get additional pills for every month. When they buy, they get 10 days of the drugs free. And last but not the least is our supplement, which is ideal for all chronic patients who suffer from hypertension or diabetes, as it offers all vitamins as well as amino acids as well as zinc on it. And as we always say, the 5 important tips for healthy lifestyle: exercise at least 30 minutes a day, and nutritious food with fruits and vegetables. And obviously we have to drink adequate water, and at least 6 to 7 hours of sleep is recommended. And last but not the least, please do not close the day without 10 ml of amino pep. Thank you very much, doctors. Thank you very much for once again giving opportunity for Indus Life Sciences.
And thank you very much for always being a supporter of the Caribbean College of Family Physicians Jamaica chapter. And we know that whenever we call, you are always there to meet the call. And we do appreciate your ongoing support. This brings us to the end of session 1. And it would be a good time for us all to stand, take a deep breath, and stretch. So wherever you are, you want to just get out of the chair, shake the body a little bit, stretch, take a deep breath, and then sit back down. And now we move on to session 2. And in a perfect world, you would see a different case. But for my sins, or maybe for your sins, I don't know who is suffering, but I will be your moderator for this session as well. And to start this session off, we are going to ask our other sponsor, Medimpex, to share with us something about their products. I believe that Sam has something that he's going to share, and I know there are some representatives here as well. If they may want to say a few words, but let's see the Medimpex presentation at this time.
Thank you so much, Doc. So I know Paulette is here. Paulette, are you there?
Yes, I'm here. I'm here trying to turn on my video, if you can do it from your end. But in the interim, I just have to put this plug. Medimpex distributes Similuton, and that's our brand of sertraline. Very, 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 very affordable alternative to the brand mentioned. All right, so good evening, everyone. It is my pleasure to join you this evening. And as you know, Medimpex has an extensive array of antihypertensive drugs. And just to name a few, we do Taliton, which is our carvedilol, or Lysopress, which is our lisinopril. We also have it combined with HCTZ, called Lysopress HCT. We do Ednit, which is our enalapril. We also do our Lysonorm, which is lisinopril and amlodipine combination, Ramlon, which is our ramipril and amlodipine combination, and the latest addition to the antihypertensive line is Amlator, which combines an anti-cholesterol medication. And this evening I'll be focusing on the Amlator. Sam, you may go ahead.
Hi, good day everyone. My name is Paulette Bedward, medical representative here at Medimpex Jamaica Limited. And today I'll be spotlighting Amlator, which is the latest addition to the Medimpex portfolio. Amlator contains amlodipine and atorvastatin, and the drug tagline is flexibility for better risk reduction. Amlator is our fixed dose combination of amlodipine, which is our calcium channel blocker, and atorvastatin, which is our statin, our HMG-CoA reductase inhibitor. Amlator comes as 3 strengths, which is our fixed dose combinations of 510, 520, and 1020. And this shows a picture of the boxes that they are available as. It's 30 tablets per box. Why Amlator? 1, because of its therapeutic benefits, the adherence component, and also the pleiotropic effects. Therapeutic benefits. Dr. Eddie Keys conducted a study titled The Success of Fixed Combined Amlodipine Atorvastatin Amlator Therapy in Patients with Hypertension and Dyslipidemia. And the goal of the study was to assess optimal target blood pressure and lipid profile. The study consisted of 2,606 patients, age ranging between 18 to 75 years old. Patients who participated in the study had to have the combined presence of high blood pressure and dyslipidemia. Blood pressure values had to be above 150/90, and importantly, they did not reach target value of 140/90 with previous therapy. Total cholesterol levels had to be greater than 5 millimoles per liter, LDL greater than 3 millimoles per liter, and triglyceride levels greater than 1.7 millimoles per liter. The study lasted approximately 2 years, with participants being observed over 1 month, 3 months, 6 months, and a year interval. Now let's look at these results. After month 1 of treatment, 42% of patients had achieved their target blood pressure of less than 140/90. After month 3, 73% of patients had achieved their optimal target levels of less than 140/90. And after month 6, a whopping 87% of patients achieved their target blood pressure reading of less than 140/90. So overall, there was a 23.1 millimeters mercury reduction in systolic blood pressure and 10.4 reduction for the diastolic blood pressure. When it comes to the lipid levels, after month 1, similar results were obtained. 42% of patients had achieved their target of less than 4.5 millimoles per liter in total cholesterol and less than 2.5 millimoles per liter in LDL. After month 3, 77% of patients had obtained these results, and after month 6, 76% of patients had achieved their targets. So in concluding, antihypertensive and anti-lipid therapy with a fixed combination of amlodipine and atorvastatin can be used safely with a high level of success in high-risk antihypertensive patients with dyslipidemia. And that's the conclusion from the study. Adherence. Complexity of therapy is a primary deterrent of treatment effectiveness. Fixed-dose single-pill therapy with Amlator provides several options that help achieve improved patient adherence. The use of fixed-dose combination therapy will reduce the number of tablets, resulting in better compliance with treatment recommendation. And this graph shows that the adherence with both a statin and a calcium channel blocker is greater compared to the single pills only. And remember, drugs don't work in patients who don't take them. Amlator has pleiotropic effects. And the pleiotropic effects of a drug are the actions other than those for which the drug was specifically developed. And these effects may be related or unrelated to the primary mechanism of action of the drug, and they're usually unanticipated. The pleiotropic effects of Amlator, there is increased presence of nitric oxide, reduction in insulin resistance, reduction in the inflammatory parameters. There's improved presence of the tissue plasminogen activator as well as its enzymes, improved arterial wall compliance of both the small and large blood vessels, and also a reduction in the left ventricular mass. So Amlator, amlodipine plus atorvastatin gives a synergistic effect. Patients suited for Amlator: those who are starting therapy, substitution therapy in patients on monotherapy, switch therapy in patients treated with similar drug class, additional therapy in patients already on similar drug class. And in the Gemini study, patients with hypertension and coexisting dyslipidemia are treated with fixed combination as starting therapy and also as optimized current therapy. What also makes Amlator desirable is that there's no particular time of administration. It can be given any time throughout the day. It can be given morning, noon, or evening. Cost. We know cost is a major factor. Prices are very affordable for each of the strength. Cost to the patient after NHF subsidy is less than $200 for a month's supply. And just a few reminders: Amlator, the single pill therapy, provides flexible dosages that help achieve improved patient adherence. Amlator is the powerful combination of amlodipine and atorvastatin that provides 3 different strengths to allow adaptable treatment. Amlator, proven efficacy in primary prevention of cardiovascular events. And Amlator is well-tolerated fixed combination therapy that provides long-term CV risk reduction. And thank you very much for having Medimpex this afternoon, and remember to prescribe Amlator.
Any
All
final
right.
words?
Just highlighting the cost, less than $200 for a full month supply of the Amlator. So it's even cheaper or more affordable than writing the individual molecules.
Okay. Thanks very much. And of course, thanks also to Mediplex, who are one of our ongoing dependable sponsors. And we do appreciate your ongoing support. So thanks very much.
Thank you. It's our pleasure.
Okay. So now we're in for a special treat, a panel discussion where we're going to look at what can be done to reduce the numerous uncontrolled persons with hypertension. And we are so blessed this evening to have 3 senior family physicians from across the Caribbean to give their input on this topic. I'm going to say a little bit about all 3 at the start. Then I'm going to give each of them a time to share their thoughts on the matter. And then we can go into the question and answer. We'll see how it develops. But let me first of all tell you a little bit about the persons who are going to be sharing their thoughts and expertise with us tonight. From Antigua and Barbuda, we have Dr. Jose Humphreys, who is a respected physician, published author, research scientist, radio talk show host, missionary, singer-songwriter. He graduated from the American International School of Medicine and has done a number of studies, a master's in allergy from the University of Southampton, a certificate in epidemiology from the London School of Hygiene, a master's of internal medicine, University of Edinburgh, and he has also done some research while pursuing his postgraduate work. He completed a fellowship in family medicine, and he works at Jubilee Regional Medical Center, where he serves as a medical director. He's a life fellow of the Inter-American College of Physicians and Surgeons, member of the European Academy of Allergy and Clinical Immunology, member of the Royal College of Edinburgh, and of course, a member of our own Caribbean College of Physicians. And just to say, he is also co-founder and chief executive officer for St. Sampson, the hospitable mission, which engages in missionary medicine and charitable relief work where needed. And he has done so in Haiti, Eastern Europe, and South America. So we are very happy that he's going to be sharing with us. Let me do the other person who is from abroad, who we might not know so well, although I have known him for many years. Dr. Colin Alert, a family physician from Barbados, is founder and director of the Wellness Clinic, Bridgetown, Barbados, former researcher with the Chronic Disease Research Center in Barbados. He has been a team physician for many sports teams, Barbadian sports teams, going to the Commonwealth Games, the Youth Olympics, Central American and Caribbean Games, a member of the National Anti-Doping Commission, and a member and former president of the Barbados Sports Medicine Association. He is a UWI graduate. He did his family medicine training with us at UWI, and he also has the experience in sports medicine as well. And I think we mentioned that he is the director and founder of the Wellness Clinic in Bridgetown, Barbados, where he has practiced for 21 years. Colin, I think we can say it. We are proud of our status at this stage. So that is a little bit about Colin. Now, I don't have any written thing about Dr. Arnold J. Brown Morgan, but I don't need anything written about Dr. Arnold J. Brown Morgan, because this is someone I have known for what term did Mr. Heron use? From way back. I have known Dr. Arnold J. Brown Morgan. We did our family medicine training at the University of the West Indies way back when. And she is a very, as you all in Jamaica know, a very active member of the CCFP, both the regional and Jamaica chapter. She holds the executive position. She is the current treasurer of the CCFP regional, and she is very active. She has been in a family practice since she graduated. We won't say when we graduated from the family medicine program, and we'll leave that up in the air. But I am sure that all of you who attend conferences regularly know Dr. Arno very well, and we are very pleased that she is also going to share with us. So Dr. Humphreys, Dr. Brown Morgan, Dr. Alert, we look forward to hearing from all of you. I am going to invite Dr. Humphreys to lead off. Dr. Humphreys, I am hoping that you are hearing all of this.
Good evening, everyone.
Okay. Are you Happy to lead off?
Yes, please. That's fine. Thank you so much.
All right, go ahead.
Yes, we are discussing a very important topic tonight, and it's something that's very common among us, and that's the issue of hypertension. Now, I want to look at it from a standpoint of looking at the root cause of disease in regards to the management of disease. It's something that I see in my private practice quite often, and even when I supervise medical students from the University of Bristol, and quite often in their minds, they're very happy to jump to the prescription of medication rather than, going through the rigors to understand why that patient might be presenting with hypertension or any disease, as a matter of fact. Now, in the area of medicine that I want to look at is something that is now evolving called functional medicine, which is a systems biological based approach that focuses on identifying and addressing the root cause of disease. It's a personalized approach to healthcare that treats the whole person and not just isolated symptoms. And the goal of this area is to restore optimum health and the function to the body by addressing the underlying cause of the disease rather than just treating the symptoms. And I think that Dr. Williams Green, had touched on a lot of the areas. As a matter of fact, I wonder if she had a sneak peek on my presentation, because she covered a lot of the aspects that I would have wanted to touch on. Now, there are many causes that of disease that can contribute to hypertension, and we're looking at factors such as poor diet, smoking, excess alcohol consumption, stress, obesity, genetics, and depending on the severity of the symptoms or the high blood pressure, we can either use monotherapy or complement it with other modalities and lifestyle changes. So we already know what hypertension is. And the two areas we want to look on is essential hypertension, where no particular cause has been identified. And then secondary hypertension, which will be more of a focus for us, focus for me within my discourse this evening, because that involves the secondary cause of diseases. And, secondary hypertension is the elevation of the blood pressure due to some form of identified medical condition. And when we compare it to essential hypertension, the prevalence of secondary hypertension is quite low. Dr. Green had mentioned it to be around 5% from her discussion. However, it is important to recognize that when we're screening for secondary medical condition, it is important that we address those issues in their totality rather than trying to treat individual issues. And we can't get away from the holistic look at lifestyle changes, diet, medication contributions to high blood pressure, and even supplements that can raise the blood pressure. So it's important as family physicians that we get a detailed history and we evaluate and assess that patient, their medical history, their medication history, their lifestyle, and do a holistic evaluation in order to understand how we are going to address their hypertension. Now, what are some of the common signs that warrant an investigation for a secondary cause of hypertension? These include hypertension resistance to therapy, a sharp rise in blood pressure in a previously stable patient, the onset of hypertension in a patient younger than 30 years of age, particularly without risk factors, and the onset of hypertension even before puberty is another factor. Or patients with, extremely high blood pressures, that is blood pressures over 180 over 110, and patients with end organ damage, patients with edema that present with edema, and hypertension with electrolyte imbalances. Now, what are some of the possible etiologies when we look at the root cause of disease? Now, a very important area that I want to look at is the obesity-associated hypertension. And, clinical animal studies have, aptly documented that weight gain can raise arterial pressure, whereas weight loss has tremendous beneficial effect on blood pressure control. And lifestyle modifications that promote weight loss are generally recommended as the first line of treatment for the increasing problem of obesity-associated hypertension. Now, obesity can cause excessive sympathetic nerve activity, and this is the activation of the sympathetic nervous system, which is a common feature in obesity. And it's widely recognized as a major contributing factor to the development and the maintenance of hypertension. And the mechanism of action within this particular area of obesity-associated hypertension is the increased sodium retention. We also look at brain mechanisms. There's a wealth of information about the neuronal mechanism that contribute to obesity-associated hypertension, and sympathetic overdrive have been gathered in recent studies, as a matter of fact, in very recent times. In particular, the brain melanocortinogenic system has emerged as a crucial molecular pathway in the development of hypertension and other cardiovascular diseases. So when we look at obesity-associated hypertension, we would have a better appreciation, considering these factors, as why weight loss is so essential in treating persons with hypertension. Yes, we can start them on their whatever treatment or medical treatment that they may have, but there might be a better response to their medication, and in time they might be able to reduce or even eliminate the need for medication if they have adequate weight loss based on the studies that have been presented. Now, there is also adipocyte-derived aldosterone, which has emerged as a new paradigm in linking obesity with vascular disease. Adipocytes were found to possess the component necessary for aldosterone synthesis, and this is a very important point. We also look at obesity in regards of the renal mechanisms, and the volume expansion and sodium retention are major features of obesity, and these contribute tremendously to high blood pressure trends. Also, other root causes can be renal disease, and this can be associated with diabetes, interstitial kidney disease, polycystic kidney disease, and these are some common secondary causes of hypertension, which account for about 2.5 to 5% of all the cases. More than half, and this is a significant point, more than half of patients with kidney disease have hypertension, which worsens as the kidney disease progresses. And so this is a very important issue that we must focus on. And so it begs for us as family physicians to evaluate patients thoroughly to ensure that we are covering these areas. Another area that we can look at is vascular alterations. And, alterations in the vasculature, including structural changes, endothelial dysfunction, enhanced contractile response, and altered stiffness are hallmarks of obesity. And these vascular anomalies are thought to contribute and even predict the development of hypertension. So those are that was a quick look at the secondary etiologies in regards to hypertension. There's also the endocrine disorders like Cushing syndrome. I won't go into that because Dr. Green had touched on these. Hyperaldosteronism is another one. Hyperparathyroidism, where the parathyroid gland secretes excess parathyroid hormone, which increases serum calcium levels. So these are other things that we can look at. Thyroid disease, whether it's hyper or hypothyroidism, can have enormous effects on the blood pressure. Vascular disorders, hypertension may occur secondary to, stenosis or narrowing of one or both renal arteries, usually caused by atherosclerosis. Coarctation of the aorta, which is a congenital condition where there is an narrowing of the aorta, as high blood pressure in and so that's
Dr. Humphries, we seem to be having some internet instability. Can you hear me?
Yes, ma'am.
Okay, try again. You're breaking up a bit on my side. I'm not sure about others.
You hear me now?
Try again.
Are you hearing me?
Yes, that is better now.
That is better.
Yes.
All right. So I will. Sure. Thank you. So I was touching on the sleep apnea, which is another factor. There are medications that and supplements, and so that can increase your blood pressure, like NSAIDs, stimulant medication used to treat ADD and ADHD, sodium-containing antacids, antidepressants, appetite suppressants, nicotine, PDE5 inhibitors like Viagra, and there's herbal supplements also, like St. John's wort, your Himbi, licorice, those that contain a lot of caffeine, and things like ephedra. These are some medical and medication and supplements that can increase blood pressure. Other factors include vitamin deficiencies like biotin, vitamin D, vitamin C, B1, choline, magnesium, coenzyme Q10. That's another factor. Toxic levels of mercury. Other factors can include stress and poor sleep habits, excessive sodium intake, the lack of dietary potassium, which is another factor, magnesium deficiency. Magnesium plays a very important role in relaxing the blood vessels. Chronic systemic inflammatory conditions, elevated blood sugar as seen in metabolic syndrome or prediabetes, which can be related to hypertension, and of course, hormone imbalances such as estrogen deficiency, which can also lead to high blood pressure. Now, very quickly, what are some of the clinical assessments that we can use? We can carry out a basic cardiovascular evaluation. We can run labs like the CBC, complete metabolic panel, do a renal function, an assessment of the mineral levels in your body, electrolyte assessment, C-reactive protein, a lipid panel, urinalysis. These are some of the things that can be used. And panels like this act as a baseline evaluation in determining a patient's risk of particularly cardiovascular disease or other conditions, and screening for other contributing factors to that disease process. We can do a hormone panel, your thyroid levels, do your serum cortisol levels, serum aldosterone levels, your plasma metamorphines and so on. Those are important things that we can do as a screening, heavy metal tests like for mercury and so on. These are general tests that we can do to get a baseline to understand what the patient's status is, and if there are any secondary causes that can affect the blood pressure. And of course, these findings will inform how we go forward with treating the patient. If there's a vitamin deficiency, then we would mineral deficiency, then or electrolyte deficiency, we can treat it in that fashion. If there's an offending drug or supplement, we can remove it, and if it's important medication in treatment, we can supplement with something else. So this is the key area that I want to look on and emphasize the root cause of disease in identifying the root cause of disease in the management of hypertension. So the key takeaway points for me that is that the identification and the management of hypertension may not just be our sole responsibility as family physicians, but as family physicians, we are frontline in regards to assisting that patient in the management or even terms of referring that patient for specialist evaluation or treatment. The aim of my presentation basically was to broaden the understanding of the disorder, so that the root cause can be determined for a more efficient and more effective and targeted approach to treatment. So as family physicians, we must understand what the disease process is. We must assess the patient thoroughly, do a thorough evaluation. We must, in light of that, identify the root cause of that disease process, refer where necessary, and treat if applicable. And this, I believe, can go a long way as a complement to the management of hypertension. That ends my presentation. I'm very thankful for the opportunity to share my thoughts with you.
Thanks very much. You introduced a number of concepts there. Of course, the very important concept of needing to look for underlying reasons for the hypertension, the whole issue of the whole sort of functional medicine, something that we can talk more about, and the vascular and metabolic pathways by which we may have obesity-related hypertension. So really a lot of food for thought, and as we go on, we can explore that a little more. What I want to ask at this time, I'm going to ask Dr. Anna Morgan to share her thoughts.
Okay, let me try and screen share.
Sure.
Screen share.
So while she's looking for that, later on, would you be able to open the mics of attendees if they wanted to talk?
Yeah, definitely. I'll just ask
Okay.
them to raise their hands,
Right.
and I can activate the microphones.
So later on, we'll do that.
Sure. Dr.
All right.
Arna, I have your screen up. If you're okay, just let me know and I'll switch through for you.
Okay, I'm
All
ready.
right. Go ahead.
All right. So we have heard quite a bit this evening from both Dr. Williams Green and Dr. Humphreys about root causes of hypertension and how difficult it is to determine the root cause before you even get to management. And then beyond the management in terms of trying to prescribe medications and other various methods of controlling hypertension. We actually just have to deal with, as a family physician, with the patient that we see face to face. Why are our patients not having their blood pressure controlled? What are the reasons that we can do, that we come across in our office? So I want to speak a bit here to what we can do to reduce the patient population with uncontrolled hypertension, by starting with some of the reasons why we actually come across the problem. What are we experiencing in our patients in our office? So what are some of the reasons? Let's start with some of the obvious reasons. Some patients won't accept the diagnosis of hypertension because they don't have any symptoms. And that's especially so with youngsters. And this often leads to medication non-adherence. And this occurs for many reasons. Patients don't take their medications as prescribed, and this is fairly common. Research shows that patients don't take their medications as prescribed approximately 50% of the time. And this has really bad consequences for patients with the chronic diseases, especially when they have hypertension, and can have the outcomes of cardiovascular and stroke. So the other thing that most of us perhaps have not really accepted is that most of our patients' non-adherence to medication is intentional. Patients make a rational decision not to take their medicines, and this is based on what they think is their knowledge and their experience with medication and their beliefs. Patients are often frightened of the potential side effects. And you notice that in your office with your patients. They ask you, or if they're afraid to ask you and they come back, they will tell you that they've heard from their friends or other relatives of side effects with those medications. And so they've made a decision not to take it. They have witnessed the side effect problems with other family members or friends. So that is one reason. And there are several others that we experience with our patients in our office. A major barrier to adherence for my patient often is the cost of the medication prescribed. This leads to patients not filling their medications or maybe rationing their medications in order to try to last until the next time they see you, having bought a portion of their medications only. So non-adherence happens when a patient does not understand the need to take the medicine regularly and the nature of the side effects that the pill actually does cause. And then, of course, some patients just don't like taking pills. Those are some hard patients to deal with, especially when a patient is taking several different medications, some with higher dosing. I mean, hopefully we're not prescribing many medicines 3 times a day, because we know that most of the times the middle day dose is not being taken. And there is increased problems with non-adherence when they are taking several different medications with different dosing frequency. So that's one reason that a lot of us have with getting our patients to adhere to medication to control their blood pressure. Some patients don't feel any different from when they start taking the medication. They don't feel any different. So they stop the medication because they don't see any reason to take it. Of course, the person who was not feeling any symptoms in the initial situation is very much going to be this sort of person. They just don't feel any different and they see no reason to use it. Then our men male patients always talk about impotence because over the decades, especially with the early antihypertensive medications, people had true problems. Males had true problems with impotence. Even though they do have problems, some of our medications do cause some amount of impotence from time to time, but less so than before. And we need to talk about the worry of impotence as a side effect of hypertensive medication versus impotence from the hypertensive disease process itself. You know, many times that is the bigger cause. Sometimes a patient's condition is actually controlled, and you tell them that they're doing well, you big them up, doing well, and so they say that their problem has resolved and they discontinue using the medication. Another reason, because these are all reasons we come across in our medical practice, patients become concerned that they become dependent on their medicine. They feel that it's the medicine that's controlling the blood pressure and that without the medication, their pressure is going to go up. Hey, they are right. It's not dependency. It is the fact that, yes, without using your medication, your blood pressure is going to remain high. So again, the interaction we have to have with our patients. Again, we spoke a little bit a while ago extensively about the depressed hypertensive, and patients who are depressed are less likely to take their prescribed medications. They just have too much happening in their lives. Taking pills is like at the very bottom of their list of things to do. So depression. And we need to let our patients know that the treatment of hypertension is long-term. It's a long-term pharmacological intervention, and that medications are only effective if patients follow the prescribed treatment regimen. This is for us to really talk to our patients about. Suboptimal or non-adherence is very common. And studies show that on average, about 50% of all prescribed medications for chronic conditions are not taken as prescribed. In the UK in 2010, it was estimated that the cost of the National Health Service primary and community care prescription medicine wastage in England for antihypertensive medications was for that year at least $100 million. So this problem with patients not taking their medication is large. So what tools do we have? Holistic medicine. As family physicians, we all practice a certain amount of holistic medicine. And so when we talk to our patients, especially those who just have stage 1 hypertension or are pre-hypertensive, we talk to them about healthy lifestyles. What we also need to tell them is that managing your blood pressure is a lifelong commitment. Healthy lifestyles is not just about getting your blood pressure under control, it is a lifelong commitment. So you need to make changes with your patient which are sustainable, which they can keep performing, which they can take forward with them. So eating a balanced diet that is low in salt, the DASH diet, is quite effective. And its emphasis is on food, which is rich in calcium, and limits saturated fats, sodium, and sugars. Limiting alcohol, regular physical exercise, de-stress. When you see all those patients are coming with the hypertension and the pulse rates above 90, de-stress. Maintain a healthy weight. Get good sleep. sleep at least 7 to 8 hours a night if you are over the age of 17. Quit smoking. You can't control your blood pressure if you smoke, and you can't control your blood pressure if you drink a lot of alcohol. And then take your medications properly. So to do that, we have to let them know that we are a team and we have to work together. You have to work with a healthcare professional. You feel free to call about any aspect of your management. I will not refuse your calls. If I have to return them, I will. But if you have any concerns, we will talk about it. So when patients only take medicine but don't make lifestyle changes, the medication just doesn't work as well. So how to solve the problem of poor blood pressure control, which is due to psychosocial, educational reasons, physical reasons in terms of side effects. The importance and effectiveness of lifestyle modifications in lowering blood pressure must be emphasized. We invest time in what is important. Face-to-face visits with our patients, we have to do it. Many of us are very, very busy, but investing that time with upfront face-to-face visits certainly is going to address some of the problems that we have spoken of just now. We talk, we give them the time because it's an investment which pays off in the long run. First of all, they get comfortable with you, so you perhaps have a little less of that white coat blood pressure that can happen. But secondly, they get a chance to address to you their cares, their major concerns. When they feel comfortable, they feel freer to talk with you about them. And you talk with them about the risks, the consequences of poor adherence, and the resulting uncontrolled blood pressure, which will occur. Sometimes I have to change the medication regimen to fewer daily doses and even to monotherapy. It may be necessary sometimes to reduce the number of drugs and aim for a slightly higher but more realistic blood pressure target in some patients who just will throw out the baby with the bathwater then. So you have to be very individualistic with your patients. You have to know your blood pressure. You have to know your hypertensive patients. So we aim these days with the advent of lots of new meds, not even for twice daily medications, but for once daily medication, combination medication where this is possible. I also would like to advise our doctors to see younger hypersensitive patients more often. They're often very skeptical about their diagnosis and require closer monitoring as well as repeated efforts with this education thing and the possible side effects which can occur of poor control. Because of course they have the most to lose. They're having this diagnosis as young people. So they really do have a need to invest in proper control of their blood pressure. And of course, where genetics occur, where you have other members of the family who have this problem, where side effects and complications have occurred in terms of stroke, heart attacks, whatever, we bring this into play. We discover this in our history taking, and we bring this into play in our management. The issue of impotence is ticklish. Modern antihypertensives, as we said before, has less problems, but as we said before, they are not free of complications. But explain to men that, especially the youngsters who have this lifetime of hypertension maybe to deal with, that they will develop impotence over the years as a result of the medication, as a result of the high blood pressure, if they do not take their medication. As I say, sometimes you have to select medications which complement each other and not go to the highest dose of each one in order to prevent some of these side effects. So here in Jamaica, another thing that we have is our National Health Fund. We really need to make use of it, as this significantly decreases the cost of hypertensive medications. And so this helps to address the problem of cost and non-compliance because of that. So, and on the NHF, there are actually some hypertensive medications which are essentially free to your patients. So the benefits of NHF, please, if you don't have patients, ask them. If they're not on the NHF, please get them registered. You can do so from in your own office now. You register with the NHF and you're able to just register them at once at your front desk or in your own office. An important measure, important tool is the self-monitoring of blood pressure. It really is like an extended office where your patients with uncontrolled hypertension, you ask them to monitor and record their blood pressures. One, to decide to make sure that it's not white coat pressure, and also to determine that they get involved in taking they're involved in the process. It's not just taking a pressure, but they are involved in the process of the management. I usually give them a range, and if their blood pressure is outside of that range, then they are to get in touch with me, and they're to bring their records that they have taken to each scheduled visit. If things are not settling and they're outside of the range too often, they have to come in ahead of time. A fact, a large proportion of patients with apparent treatment-resistant hypertension are not adherent to taking their prescriptions. And up to 75% of patients with hypertension who require more than one antihypertensive agent to achieve blood pressure control. So single pill fixed combinations help to improve adherence and blood pressure control. And the other thing we talked about is that when you have these single pill combinations, what you're doing is using lower dose of each of these pills. And so you have a lower risk of adverse clinical outcomes and also a lower risk of side effects from the medications. As you notice there, statistics show superior adherence rates when you have these single fixed dose medications of 70% compared to 42%. So apart from reducing the pill burden, the targeting of different pathways by different antihypertensive agents is also very efficacious. What I want to say too is that, so we've discussed all these methods that we can use and all the reasons why they don't take their medication, but we need to realize no single method is successful in the management of hypertension. Studies show that you need to use a combination, if possible, all of these various methods and interventions that we've just spoken about in reducing the levels of resistant, what seem to be pseudo-resistant hypertension. So according to one specialist, it takes a certain level of commitment to live a healthy life. Controlling hypertension is a lifelong marathon that you're embarking on, whether it's with medication or with lifestyle or with both. It's for years to come. So you need to just realize that it helps to ensure that you will be healthier down the road. And just in closing, research has found that every dollar spent improving adherence to medication saves $7 in total healthcare costs. So thank you, and this was what I wanted to say to you tonight. Know your patient, spend time with your patient, allow them to speak with you, and combine various methods of that you have at your as a are your armamentarium. It's just you have to combine them in order to actually achieve management. Thank you.
Thank you so much, Dr. Arnold.
Okay.
We are seeing themes emerging. The whole issue of holistic medicine, forming a team with our patient, working with our patient, the whole issue of non-adherence you certainly brought to the fore and understanding the underlying reason for the non-adherence if we are going to deal with it. And he touched on some things that we can explore a little further when we go into the open discussion. So thanks so much, Dr. Brown Morgan. Dr. Alert, I see you are alert and ready to go. So please go ahead and give us your perspective.
Okay, thank you, and good night, everyone. Thanks for inviting me, and also special congratulations to the speakers who came before me. I will try to wrap it up very shortly. It was certainly interesting to hear the views of my colleagues from Antigua and Jamaica. And I will try and share a little bit of some of my thoughts about what's happening in Barbados. It's a 10-minute presentation, so I won't be too long. Can you see my slides?
But you're not in slideshow mode. We are seeing them, but you could just go into slideshow mode.
Right, okay, yeah.
There you go, we are seeing them right now.
Right, okay. All right, well, I have no financial ties with this presentation. This is the world picture, which we kind of heard about tonight. About a quarter of the world has high blood pressure. You know, it's the single largest contributor to deaths, especially in terms of heart disease and strokes. And as Dr. Brown Morgan just kept mentioning, about 50% of patients are non-adherent to therapy as soon as 1 year of starting therapy. And of course, it's a very expensive disease. And the bar chart on the left shows that 65% of people do not have their blood pressure controlled. So how do we help this 65%? Well, the short answer to this is to upgrade public health policy and resources so that we have good hypertension screening and early intervention policies. You know, and there's certainly evidence that better access to primary care improves awareness and control of hypertension. You know, so we need better primary care programs. But saying that is great. In truth and in fact, there's no country in the world that actually has achieved this. So it's wishful thinking. We haven't gotten there yet. Okay. The epidemiologists tell us that, you know, if we can reduce the systolic blood pressure by as low as 5 millimeters of mercury, we can reduce the risk of a major adverse cardiac event, that's MACE, by 10%. So in truth and in fact, you know, if we're trying to prevent heart attacks, we're trying to prevent stroke, heart failure, death, all we need to do is get the blood pressure, the systolic blood pressure down a little bit. All right. Changing tack slightly then, what can family physicians and other primary care workers do to improve hypertension management? In those that we do see, because obviously there are many people who actually come into a doctor's office, and you know, we need different methodologies to get to those, right? Now we need to enhance education, such as this forum, you know, and the 270 odd persons who are here. You know, we need to educate people on lifestyle changes, including controlling weight, eating healthy, low sodium diet, exercising more, stopping smoking, and limiting alcohol. And we need multiple approaches. You know, we need all hands on deck. So as Dr. Brown Morgan said, we need to use a face-to-face approach. We need, public health approaches. We need to use multimedia. There are many different methods, and we probably need to use all of them to try and get to the population to educate them about the importance of high blood pressure and its control. Okay. As far as family physicians are concerned, we should be doing opportunistic screening, which means that every patient that comes in through the door, we measure their blood pressure. Okay. So we should measure blood pressure in all adults, plus those are high-risk adolescents, those with a family history of cardiovascular disease, those that are unwilling or unable to exercise, those that are overweight or obese, right? And we should encourage home blood pressure measurements. Again, Dr. Brown Morgan just mentioned some of that, and I will as well, right? The advantages of home blood pressure measurements are clear. It's expensive and widely available, at least in Barbados it is, and it encourages patients to become involved in their management, right? And then we must follow this up with early intervention. But early intervention must include both non-drug and drug therapies, okay? Non-drug therapies are also important for the prevention of hypertension, as well as for its treatment, right? Now, tackling overweight, and in Barbados, our latest study, epidemiology study, shows that 66% of adults over the age of 25 are overweight or obese. Okay, so we have a big obesity problem down here, and I suspect it's quite big, maybe not quite as large as Barbados and some other Caribbean islands. But ideal body weight is the best goal, but at least lowering the weight by 1 kilogram does help a little bit, And while weight loss is difficult to achieve, meta-analysis has shown that if you can reduce, let's go again. A meta-analysis suggested that after 6 to 12 months, weight loss reduces systolic blood pressure compared to placebo by a mean of 2.6 millimeters of mercury. So you do get some blood pressure reduction with weight loss. Okay. Now, obesity is a high and growing problem around here, and we certainly know that we don't have very good primary care strategies for consistent weight loss and maintenance of weight loss. And unfortunately, the newer weight loss drugs and surgery are very expensive. Another issue related to obesity and overweight is that of obstructive sleep apnea, which some have mentioned before me. And this condition is certainly more common in people that are overweight or obese, right? But screening for and treatment of OSA lags behind hypertension, in part because, of course, certainly in Barbados, it's very expensive to send people to see specialists. So that, even though we know that in theory, a lot of the obese people who have high blood pressure probably have obstructive sleep apnea, we haven't been able to treat many of them, because of cost. Alcohol is another big issue, okay? And apart from doctors who work in and seen car accidents and psychiatrists, and maybe all of us here tonight, almost all of the rest of the Caribbean think that alcohol is a good thing, So everybody loves alcohol, and certainly culturally, used to judge men by how well they could hold the liquor. So, people were judged by how well they drank, and certainly in Barbados as well, our anti-doping people have said that there's a rise in binge drinking in young females. So even girls and young women are getting into drinking. And that's a problem, when we're dealing with high blood pressure, right? Alcohol raises blood pressure and causes liver damage. And I read compared to statins, when you try to tell patients, well, you need to take this medication for your cholesterol, nah, doc, that doesn't affect your liver. I read that on the internet, But when you tell them, well, drinking can affect your liver, No, man, I go and take my drinks, man. That help me relax and calm down and stay cool, so that people have a different view of what affects the liver. Alcohol certainly does, and statins probably don't, or very, very few cases do. But the perception is a little different from what actually happens. Well, there are recommendations for how much drinking is actually allowed. People don't follow that, but there are actually recommendations. But we know that alcohol avoidance can lower the systolic blood pressure by 4 millimeters. And people who drank one alcoholic beverage per night showed a link to higher blood pressure when compared to non-drinkers. And again, other data has showed that increases in systolic blood pressure rise with the number of beverages consumed. So alcohol, as far as high blood pressure is concerned, is not a good thing. Okay. Diet control is also important. And we live in a world where there's lots of fast food diet, that come with salt, sugar, and fat, all of which contribute to high blood pressure, diabetes, and dyslipidemias. When consumed in excess and combined with inactivity, these lead to hypertension, diabetes, and dyslipidemia, as I just said. And the DASH diet, which was just mentioned again by Dr. Brown Morgan, it's a diet rich in fruit, vegetables, whole grains, and low-fat dairy. And certainly data from the National Heart and Lung and Blood Institute suggests that the DASH diet can reduce the blood pressure, systolic blood pressure, by as much as 11 millimeters of mercury after 1 year, or after 1 year of DASH diet. And if you're trying at a minimum to drop the systolic by 5, then the DASH diet is great. It's great as a preventive tool. It's great as a therapeutic tool for keeping the blood pressure down. We kind of all know this. As the blood pressure goes up, systolic on the left, diastolic on the right, the dangers of cardiovascular complications goes up. So the higher blood pressure is, the more problems you're going to run into, okay? It's a little more involved than that. Now, this table shows a number of columns, and as you move from left to right, you have higher and higher blood pressures. And in the old days, we used to think that the higher your blood pressure is, the more problems and the more danger you are of having a heart attack and having a stroke and dying and so on. But we now know that if you have a pressure that's sort of relatively normal, but you have risk factors, or you have organ damage, or you have advanced kidney disease, or advanced diabetes, or organ damage, that also puts you at high risk. In other words, we need to be more aggressive in treating blood pressure, based on what else is happening in the patient. So you can't only judge a patient that, hey, your pressure is too bad, man, go long and take it easy. We need to assess the blood pressure, but we need to see what are the risk factors, what are the organ damage disease, whether there's kidney problems, whether there's diabetes, because those also influence the damage that our blood pressure can do. Right? So we need to get back to the basics that we learned in medical school. We need to take a history, and in that history, we need to find out about previous cardiac events, whether the person had a stroke before, or a TIA, a heart attack, chronic kidney disease, peripheral arterial disease, erectile dysfunction, or senility, which came in, We need to ask about comorbidities, obesity, diabetes, dyslipidemias, right? And then specific things in the clinical examination is obviously the blood pressure in and of itself, but the eye changes, because hypertension can cause eye changes. We need to check for arrhythmias, because hypertension can affect the heart. We need to look for a large heart. We need to look for an abnormal ECG. We need to check the urine, because chronic kidney disease is a critical component of disease associated with high blood pressure. And what's relatively new is the cardiovascular risk tables, which I'm not going to go in tonight, but that's an important tool now in managing a patient with cardiovascular disease. So this is just saying some of the same things. In evaluating a patient with high blood pressure, We need to look for demographic and biological characteristics, overweight and obesity, family history, and so on. We need to look for hypertension-mediated organ disease, which is HMOD, ECG problems. We need to check the urine. We can check the ankle brachial index and so on. And then we need to confirm or otherwise whether it is established cardiovascular or renal disease, stroke, coronary artery disease, peripheral artery disease, heart failure, atrial fibrillation, heart failure. And then, in addition to the non-drug therapy, and I just mentioned some, in my presentation, I can't mention all in 10 minutes, but we need to use 2 drug combinations, also called fixed dose combinations, right? It improves the blood pressure lowering. It improves the speed at which we achieve target blood pressures. It helps overcome therapeutic inertia. It helps reduce variability in blood pressure response, okay? So the new guidelines suggest that we start with, single pill combinations. Dr. Morgan mentioned some of this, and again, I won't go through this whole slide, but there are different steps based on your blood pressure, how, if you're not controlled at step 1, you move up to step 2, move up to step 3, and so on. And by the time you reach step 4, you're either thinking resistant hypertension or you need some other assistance anyway. Right, so in summary, so this is my last slide, so I've kept up my 10 minutes. Effective hypertension management is a global challenge. And at the national level, we need enhanced public health resources. At an individual level, we need to focus on total cardiovascular risk. So it's not only blood pressure and the magnitude of the blood pressure, but other cardiovascular and target organ things that go along with it. And then you must select non-drug and drug options that can achieve blood pressure targets and offer cardiorenal protection. And thank you, ladies and gentlemen. That is my little piece for tonight. Thank you.
Thank you ever so much, Dr. Alert. Again, the common threads, the lifestyle changes, the importance of primary prevention, the use of combination drugs to cut down the pill burden. All of these things are important. I'm going to ask persons who want to ask questions or make comments to raise their hand, and then Mr. Heron will open your mic so that you can speak. There was one question that has been answered already, but there's one that is still open, asking what are the treatment options for patients who are unable to cope with increased urinary frequency and nocturia caused by diuretics? Anyone who would like to give an opinion on that one? Arno?
Sorry, you said that, repeat the question, Aileen.
If someone finds it difficult to deal with the frequent urination and nocturia, what do you recommend instead of diuretics?
Almost any other combination,
right.
It depends on what's wrong with the patient. If they're having cardiac issues with water retention, they're going to need to take some component of a diuretic. But if it's just hypertension alone, then there are many combination pills and that can be used. It's not necessary to use a diuretic. If there is a need to use the diuretic, though, then you can choose when there are certain newer diuretics don't cause the water loss as quickly or as noticeably as some of the older ones. So you can try the newer ones and perhaps lose the water more slowly. But it depends on what's wrong. If there's a cardiac burden that has to be dealt with, then it has to be dealt with. This could be a crisis otherwise. So it's going to depend.
Absolutely. Anyone? I have not seen any raised hands. I don't know, Sam, if you're seeing any. It may not be a question. It may be a
Not
comment.
seeing any yet. Not
It
seeing
may
any
be a
yet.
it may be a comment on if there are any things that weren't mentioned that you think could reduce the number of persons with uncontrolled hypertension. Certainly a problem that we see every day in our practice. And all three of our presenters have put forward. If you notice, all three of the presenters, Dr. Williams-Green earlier, have emphasized the need for lifestyle changes. And this being a lifelong commitment, not only on the part of the patient, but also on the part of the caregiver as well. We have to commit to spending the time with the patient, as Dr. Brown Morgan said, talking to the patient, engaging them, finding out why are they not adhering, and working with them.
And we doctors can also be more representative of the situation. Because there are so many of us that have become couch potatoes, and we're not, we could exercise more. We could be a little slimmer, and definitely we can take our own advice to them with the diet. So we are not without the complications within our own ranks.
Absolutely. We do have to improve on our side as well, so we can advocate to others. As they say, take the mote out of your eye first before you try to take it out of someone else's. If there are any comments from the panelists based on what others said, anything you want to add, you could do so at this time.
Yes, Eileen. I'm not sure if everybody's hearing me.
Oh yes, Dr. Ricketts Rooms, I recognize the voice. Go ahead.
Just to also focus on clinician inertia. The fact that sometimes we seem to be, one, afraid to make the diagnosis, two, be very explicit with the patient as to what is going on. You know, these terms such as just a little pressure or it's a little high, you know, sometimes sets up the patient to not take things as seriously as they ought to. I think we need to be straight with our patients, not scare the bejesus out of them, but let them know exactly what's happening. Because I find a lot of patients, when you speak to them, you know, they may be managed somewhere else, or they, having spoken to them, you know, patient education, etc. It's almost as if some of them will say, not to say that nobody has ever spoken to them, but they did not realize that all of this was a part of the process, or, you know, exactly what hypertension can do. In fact, some of the problems I find too, we have to treat it as a chronic illness. Chronic illnesses, we really ought not to be giving people prescriptions. I hope that they come back when the prescription is finished. We're supposed to be giving them regular appointments. And these appointments must be in keeping with the level of control that you've assessed on your most recent visit. You know, sometimes you just give them a prescription for 6 months. You assume they're going to come back in 6 months. They could have had 3, 4 prescriptions from another set of doctors. They don't see them again until another year. And they remain uncontrolled because as far as they're concerned, doctor never tell me to come back. So I figure I must just come back when the prescription finished. So there are lots of things I think we need to change to in terms of our approach to the patient, so that they recognize that this is how it really should be. If you're uncontrolled, you really should be seeing the patient within a month. Depending on how badly uncontrolled they are, it might be 48 hours. It may be a week. It may be a month. But it can't be that I understand, having worked in the public health system, I understand the limitations of space and time and human resources. But at the same time, if you're in private practice, you ought not to have that problem, you know? So monitor them as urgently as they need to be monitored. Just like just like how we manage patients with HIV, which is another chronic illness, we see them according to how they are clinically doing. So it's the same thing for hypertension. Can't be that we're giving 6 months and the patient's blood pressure is 150/94. They're still uncontrolled. You need to see them more often, get out of this patient inertia, make the diagnosis when we need to, and talk to our patients and treat them as if they will understand what we're saying and don't think that these ambiguous statements that we give them that will help them, because sometimes it just confuses them. So that's my, some of the
Thanks very much,
Yes,
Tana. Thanks for that. Very useful. Go ahead, Anna.
Right. One of the things that in addition to what Tana said, is that we probably need to at intervals ask our patients to carry in the burden of tablets that they have at home.
Always.
Let us see
every single one.
all of them in.
Yeah.
Let us see everything. And this is the supplements as well as, say you even, if you can't do it regularly, say you even do it even one time a year, because then you're going to see what is yours, what label from another doctor, how much medication is left over, and you have a frank, this opens you up to having a frank discussion with the patient about, yes, as you said, skipping from doctor to doctor and why they are doing it. And ask them, why is it you have come to see me today? Why are you here today? How can I assist you? Let us try to set up a relationship in which we can trust each other. Explain why you need to see them back. Even if you are in a very busy practice, if you can set up that close knit link with your patient up front. First time you're seeing them with the hypertension, and you just tell them, "Whoa, this is what is happening. It's a lifetime investment. These are the side effects. This is what can happen to you if you don't take them." Let them understand how dangerous it can be, and let them know that they don't have to be scared of the management, especially if they control everything, catch it while it is still in the earlier stages, combine it with diet, exercise, weight loss, and so forth. I saw a question there where, as we had said before, someone was asking if the individual is more at risk to develop ED by being hypertensive or by being on antihypertensive drugs. And the answer to that is, of course, by being hypertensive. All those macro and microvascular disease that is taking place in the blood vessels, of course, remember that your impotence is often a precursor, is used as one of those soft signs to let you know that you may be heading for some sort of cardiovascular event. So yes, you can try to monitor side effects of ED with medication, but the side effects that occur with the disease are not reversible.
Good one, Dr. Brown. Describing ED as a soft sign.
I know. I
describe it that
do
way.
know.
Yeah, but the cholesterol is also critical as well, because if you have plaques in those arteries going to your penile, going to your penis, you're not going to get enough blood in to get a hard erection. So the cholesterol story is an important part of that as well.
Dr. Alert, how did I know that you were going to pick up the soft sign? I've known you too long.
It looks so.
But it is very true that the sign of atherosclerotic disease, ED, can often be the earliest sign we have that there is atherosclerotic disease going on, even before we see it in the eyes or see it in the heart.
Or the kidneys, the peripheral. Yeah, that's quite true.
Yeah. Okay, I don't think I can see the hands. Sam, you can guide me there. I don't think there are any more hands, are there?
No more at the moment.
All right, and I think that we have had a very good evening. Jose, Khalid, Arda, you have shared your perspective, and what is coming through so clearly is the common threads wherever you work, whether in Antigua, Barbados, Jamaica. There are common things that affect all of us, and things that we can do to try and reduce this number of persons who have uncontrolled hypertension. So thank you, the three of you, very much for sharing your perspective. I won't steal any more thunder from Dr. Levy, who's going to do the formal vote of thanks, but it was really a pleasure listening to the three of you and interacting with the three of you. So thanks very much for taking the time out.
Thank you.
Thank you.
And good to see Colin. Good to see you after all this time.
Yes, thank you.
Jose, I don't know you personally, but I hope to meet you in person at some time. All the best.
Thank you so much.
Okay, so we have had a very, I think, fruitful evening, a time well spent. And I'm going to ask Dr. Dane Levy, who is the secretary of the honorary secretary of the Caribbean College of Physicians Jamaica chapter, to do the formal vote of thanks. Dane?
Good night, everyone. I was hoping, that are you hearing me, by the way?
Yep, loud and clear.
Okay. I was hoping that you guys would have timed the meeting so well that I would have been home by the time it was my time to give the vote of thanks. I'm about 2 minutes away from home. So your timing is a little bit off, but nevertheless, I will attempt to give thanks to everyone that has participated in this webinar this evening, which is so very timely and so important. I'm just making a few comments before I get into the official thank you, because I have a list written. I'm not trusting everything to memory. I have a list written, and I'm about 1 minute away from home now, so I can consult my list in about a minute.
Okay.
But I wanted to say that the webinar has been really excellent. We looked at things from all different perspectives, and we underlined the challenge of managing hypertension in the primary care setting, which indeed is a really big challenge. And we spoke to so many different aspects and the small percentage of patients that are really properly controlled. And we spoke to some things we might have spent a little bit more time on, and that would have given us a little insight into why control is so difficult in terms of the cultural and social aspects and the influence of social media nowadays on our patients and what they hear and what they see from all different angles. I know they don't want to get addicted to this medicine and what this medicine going to do to them and all these different kind of things. And next thing they turn up in the office with a stroke. These things can be so devastating. It helps us to continue to have these discussions, these webinars, not just to but to develop strategies to tackle the real root of the problem. And I mean, it's a root with many different, what should I say? Roots don't have branches, but whatever is attached to the roots. There are many different sides to the challenges that we have. I'm about 10 seconds away from home now. There are many different challenges to this real effort to control hypertension, but nevertheless, it is worth our while. And I really did enjoy hearing, especially from Colin. Colin, a hearty good evening to you. Anybody, I think Alden knows.
Greetings, my brother.
Let us we'll allow
Here
Dr.
it
Levy
was.
to park and get to a safe position so that he can continue.
Yes.
Dade, we want you to be safe.
Okay. Okay. I am a
We know that from your comments, we can hear that you've been listening all along, and we'll just give you the time to pull in. Please remember, all participants, there is a post test. If you look in the chat, you will see that the link for the post test was posted. I know I saw it a little while ago. And Sam, maybe you could just post the link for the post test again. So some comments seem to come in after that, and it's a little bit further up.
So what I'll say is we want to thank everyone for attending. Dr. Levy, are you in now?
Yes,
looks like you're inside now.
He's in a safe place now. So if you could, so remember that you
Yes,
have to do the post. So over to you, Dr. Levy.
Go ahead, Dr. Levy, with the vote of thanks.
Wonderful. I hope.
Yes,
Right,
I'm sure, Dr. Levy. I'm sure Dr. Alert would have something to say about the importance of timing.
Okay. I think you can hear me now.
Yes, we can hear you now. Please go ahead. Thanks very much.
All right. Aileen, moderator, and the graciousness with which you were able to maneuver and control this program was evident. Sam, I heard you say that's why I'm here tonight. So I've been to many of the webinars that you offer, the kind of service that you do, the kind of efficiency. Thanks to you.
Dane, your bandwidth seems to be low. Maybe you need to turn off your video. Your bandwidth is low, so you are breaking up a little. So maybe if you take off the video, let's work with audio. Sam can tell me if that is good advice or not. Oops. Not sure why you're breaking up a bit.
I have changed my location.
That's good.
So
That's good now. That's good now.
Okay. All right then. Okay. So I was thanking Sam. I thanked you already, Aileen, for your wonderful job this evening, and Sam for providing the support. Aldit for offering prayers for us at the beginning, or opening remarks by our president, Dr. Seni Onanuju. And of course, our two presenters, Dr. Pauline Williams-Green and was it Dr. Eaton? I think it was Dr. Eaton. I hope I got his name correctly. They did a wonderful job in their presentations, and of course, giving us different perspectives of the challenges of managing hypertension. Our panelists, Dr. Humphreys, Dr. Arna Brown Morgan, and Dr. Colin Alert. Of course, there has to be a common thread through all of this, but each did very, very well in presenting different aspects of the various different challenges in terms of managing hypertension. And Arna gave her presentation from the angle of the patients, what challenges the patients face. I think Colin looked at it some sort of public health aspect, I think. But everybody did give a really good presentations. The panelists, as I said, and the presenters. So I just wanted to say thanks on behalf.
Have we lost Dean?
Look so.
All right.
Dr. Lynn Thompson Hyatt and their assistant, and Lawrence. Yes. And of course, we are very indebted to our sponsors, Indus Life Sciences, I think it was, for sponsoring this webinar this evening.
And Medimpex.
Medimpex was there as well. Oh, wonderful. Yes. We had two wonderful sponsors, Indus Life Sciences and Medimpex. They each are bringing different medications and, of course, emphasizing the holistic approach as well. And, of course, continuing to develop different combinations of medications to treat this chronic lifestyle disease, hypertension. So overall, our excellent webinar, and just thanks once again to all that. If I have left out anyone, please forgive me. But I think everyone did an excellent job and played their part to bring this webinar to us. It was very well received, I think, and very well attended. And just want to thank all the attendees, my colleagues from various different islands who would have attended this webinar this evening. And overall, well organized, excellent presentations and well received. Thanks again. God bless you all.
And thank you for thanking us, Dane. And it has been my pleasure to spend the last few hours with you all. I hope that you have found this webinar as exciting as I did, as enlightening and as stimulating as I did, and that we have all got some pearls of wisdom to use in our day-to-day practice. So I hope most of you are already at your homes. Those who are not, please do get home safely, and best wishes to you all. Good night.
Good night, and thank you so much to everyone. Thanks to the audience for your thoughtful questions, really interactive tonight. We thank you for taking the time. Kudos again to everyone on the organizing committee, the technical team, everyone behind the scenes. Lynn, thank you so much. And of course, Dr. Ananuju. In conclusion, we hope the event was a good source of knowledge for everyone, provided some professional growth, and we invite you to do the post-test. So once you've completed the post-test, we will confirm that persons were able to do the pre or post-test. And then, of course, the payment information was shared a bit earlier, which is how you pay for the CMEs. Thank you guys so much. Thank you. Please stay safe. And we'll see you at the next event.
And
cheers,
thank you.
Everyone. I appreciate it. Very much. Stay safe, stay dry. See you guys at the next one.